Okay, so recording's going. All right, here's our agenda. We don't follow it all that strictly. I also want to remind everybody we will do questions through the through the web interface. Everybody should be unmuted because we actually, John, can you turn the volume on the speakers for a quick second?
No sound yet.
Just the one there on the right, just turned up. Do we got any audio? Yep, turn it back off, John. So if anybody is not able to hear, that's something on your end because we just turned the audio on ours. So hopefully you can get some help if you can't hear. Thank you. Somebody did say they could hear, so it's working. You should be able to hear regardless of whether you're using your computer or the phone, even though we actually are using the computer to do the audio section. So for those who have not been aware, here's our introduction slides on our redesign, our 4 phases: elevation, expansion, modernization, which is coming about 4 days away, July 1st. So we're redoing this slide deck to get everybody moving in that direction. And then our integration, which is the carve into managed care. So there's our completion dates. Soon we'll be moving the modernization one up and begin to move more into the integration section, so more to come on that in the coming months. So a couple things we wanted to cycle back around on that we did not actually have the time to incorporate in our 301 trainings, and a lot of these policy updates happened right on the cusp of doing our last one. So we have a number of policy updates we will cover here, and you actually see in the corners of some of these, like this one, where it references slides that are in the deck that will provide additional information on these areas. So previously, MITS was configured to not allow a physician or doctor visit, an evaluation and management code, and a nursing code, either the T codes or the H codes, on the same day. That policy has been revised and updated to allow RN and LPN codes on the same day as evaluation and management services. Staffing for SUD residential. Over the course of our trainings through the years, and it's interesting to say that because we've been out there doing this now for around 2 years, we had staffing requirements for SUD residential. It was in the manual. It then moved from the manual into the ODM rules, and at this point we will actually be taking that out of the rules. If you look at them, it would say something like a physician, for part-time, 0.5 of an FTE of a physician. That will be coming out of the rules because under the ASAM umbrella, staffing expectations, service expectations are embedded in the ASAM levels of care. So for MH day treatment, SUD intensive outpatient level of care, and SUD partial hospitalization level of care, there's an update there that will allow for additional group services on the same day. So it covers 2 levels of care for SUD and on days when mental health day treatment is provided. General supervision versus direct supervision. Cicely will talk more about this later. This has been one of those kind of areas where there's been a lot of work over the time of the project. Supervision is optional at times, but you will notice down here payments are influenced by the existence of the supervisor on a claim or not. Please keep in mind this does not negate or do anything in terms of professional boards and their requirements. Documentation standards. Rules are aligned between mental health and addiction services and the Department of Medicaid. That's been through part of the JCAR and the rule filing process. Place of service, 23, which is hospital emergency room, and 99, which is other, or in this case, community. Those have been updated. At one point, they were not in the grouping of allowable places of service for some of the services, but they are now back. Please reference the Medicaid rules for some particulars on there and the provider manual. And just keep in mind that you cannot use these to bypass edits in the MIT system for individuals who are incarcerated. Transportation. Transportation in and of itself is not reimbursable. You will see that change reflected in the Medicaid rules. Keeping in mind that if in any location you're providing services, you must document the service and the nature of the service to meet medical necessity. This one is particular to assertive community treatment. Previously, the criteria to qualify for assertive community treatment was based on the Adult Needs and Strength Assessment, the ANSA. That is being updated to also accommodate individuals that have a SSI, Social Security Income, or Social Security Disability Insurance, SSDI, disability. And there's work going on to try and make that easier from the provider side to accommodate the state checking and verifying that, but more on that later around ACT. Okay. Sorry, I got a slide ahead of myself. With the transition to managed care, the fee-for-service rates will be in effect as a floor for them through December 31st of 2018. So for the straight Medicaid managed care, that's a year. And for the MyCare plans, because they are coming online with us July 1st, they will follow the rates for 18 months. That keeps them lined up, and the fee-for-service rates would no longer be the floor after January 1 of 2019. And the MyCare plans will follow the prior authorization policies for 12 months beginning this July 1st. So we are on Community Behavioral Health Center laboratories. We have worked with the managed care plans that they will bring on behavioral health laboratories that are up and operating, and they may negotiate rates. There's no guarantee on the rates being the same at this point. Outpatient hospital clinics. At one point, hospitals were going to be phased off of the provider type 84, which is a community mental health provider type, or 95, which is the community SUD. They will be able to continue as those provider types on and after July 1. And that's a note down there about the way that Mental Health and Addiction Services deems providers as certified through our certification process. Hospitals usually can qualify because they're joint commission. So, TBS, Therapeutic Behavioral Services and Psychosocial Rehabilitation. At one point, there would be a rate adjustment on those, the 50% that lined up with the current practice of rate adjustments on the SUD case management and the mental health CPST service. The only time that will occur now on these two services is when they are provided in an office setting, which is place of service 11 or 53. Office or CMHC for more than 90 minutes by the same agency to the same client on the same day. Other places of service will be paid at the 100% after the first 90 minutes. Collateral contacts. So collateral contacts are able to be covered as part of services to individuals. Understanding that that's part of collaborating on gaining information to help the individual and to inform their treatment. Okay. So now we'll jump into our quick managed care section. We just do an overview here. So these are the current Medicaid managed care plans. These are not the MyCare. These are the ones that the benefit will remain carved out of until January. So come this July, these individuals that are enrolled in these health plans, you will need to make sure, as you do today, that you're coordinating care with them when it's needed. But the benefit will remain carved out with the exception of two. The respite service, which came online February 1st, and the inpatient psychiatric services that are, there's some changes there come July 1st because of the federal changes in the managed care regulations around institutions for mental diseases. And then, as I mentioned, you need to coordinate other services as needed with the managed care plans. So the next slide, these are the MyCare plans. There's one plan which is in regular Medicaid, which is Paramount. And then when we flip over here to MyCare, Aetna comes on board. They're MyCare only. So this, because the benefit's already been carved in, it will be carved in come July 1st because it's already there. There's no point in taking it, bringing it back out just to put it back in another 6 months. So if you're seeing dual eligibles that are in MyCare plans, you will need to continue to work with the managed care plans like you do today. All right, a little bit here on the laboratories for the MyCare. You can see this one lines up with the slide 16 policy update number 10. So we've tried to mark those. Just want to let folks know about that as we go. So because laboratory is carved in here, you will need to, if you are operating a CLIA lab, non-waived, you will need to work with the plans on getting enrolled there. More to come on that as soon as we have information on CLIA waived, because those can be billed direct under fee-for-service. So people are asking a little bit about that. We will have more information on that to come. Keeping in mind that the benefit package goes in, but you will need to negotiate in terms of payments. We are not applying the 100% fee-for-services floor here. So around prior authorization. So MyCare plans will begin processing PA requests for ACT and IHBT since those are coming online in the new benefit package. All others, they will accept any that have been made by the state once it goes over. They will follow their existing procedures for doing prior authorization, but we expect some expediting, whether you mark it on the PA request or not, for ACT, IHBT, and SUD residential. So the MyCare plans have been working with the state to understand the expectation on those services is expedited PA, whether it's actually marked on the form itself or not. Okay. With that, I will swap the next section over to Mary Haller from the Department of Medicaid.
Good morning. Hope everybody's having a good Monday. So I will be covering the next section on the mental health benefit package. This slide should be very familiar to folks. We have taken a number of steps to expand the mental health benefit package, adding a number of services, including family psychotherapy, both with and without the patient, adding primary care services, labs, and vaccines to support the integration of physical and behavioral health care, adding coverage for psychotherapy and psychological testing. We have added, for the first time, bundled coverage for assertive community treatment and intensive home-based treatment. We have added some community rehab services, therapeutic behavioral service, and psychosocial rehab, and maintain coverage of CPST. We will talk in greater detail about therapeutic behavioral service and psychosocial rehab a little bit later in the presentation. And we're also maintaining the prior authorization exemption for second-generation antipsychotics that has been in place for a long time. This is what the mental health benefit package looked like before July 1, what it looks like at this moment in time. And you can see that the new benefit package has a number of additional services, which we talked about just a little bit earlier. This slide gives a quick summary of the medical services that we have added to the benefit package. You can see the evaluation and management services there for new and established patients. We also added the home-based services that are part of that evaluation and management code set. And then the add-ons for prolonged service when psychotherapy is a part of a medical visit, and the code that can be added on when the patient meets the threshold for interactive complexity, and also the code for therapeutic injection. With regard to day treatment, mental health day treatment, we have 2 ways that that service can be provided and billed. The first one is hourly. You can see the service code here, H2012, and the varying rates off to the right there, depending upon the qualifications of who the rendering practitioner is for the group. Maximum group size is 12 to 1 clinician. The person needs to attend for the minimum of 30 minutes or more. Services billed in whole units only. If the person doesn't meet the minimum, practitioners or agencies can bill 90853 or H2019 with the HQ modifier for group. And then other services can be billed in addition to H2012. And if you refer back to slide 9, when Doug did the policy updates, you can see that we have amended our policy to allow additional group counseling to occur when day treatment service is billed. The other version of mental health day treatment is the per diem version. That is when the service extends beyond 2 hours in length. You go to the per diem. Again, you can see the code off to the left, H2020, and the rates off to the right that are different depending upon who the clinician is who's leading the group. Again, the maximum group size is 1 to 12. The person needs to attend for the minimum of 2.5 hours. And if they don't meet the minimum, there are the codes that you can bill. Again, the service is billed in whole units only. And other services can be billed in addition to this. The requirement with these rates for day treatment are that the agency must be nationally accredited and the group treatment must be supervised by a licensed independent practitioner. Managed care respite, we talked about a little bit earlier. This is a new service. We modified what the service is and who can be eligible for it. It is carved in to the Medicaid managed care plans. And it started up February 1st. So if you have clients who you believe meet the eligibility criterion for respite, please refer them to their Medicaid managed care plan for access to that service. This is a reminder of the services that the policy changes that we have added with regard to children's behavioral health. We had lengthy discussions with our children's subcommittee on these. There are no diagnosis edits required for services provided to children by licensed practitioners. We've also added intensive home-based treatment, which is a service that our children's advocates said was very important. IHBT teams will have to be certified by Ohio Mental Health and Addiction Services. They will also have to meet a fidelity standard and have a review by Case Western Reserve University in order to meet the Medicaid requirements. And IHBT is a completely prior authorized service. And then additionally, we added coverage for psychological testing, which was something that our Children's Committee said was very important, and vaccinations via the Vaccines for Children program, which is administered through the Ohio Department of Health. Okay, I am going to turn it over to my colleague, Cicely Hill.
Good morning. I'm going to take a quick second before I start and answer the questions that we've got so far, just so we don't get too far behind. So the first one is talking about provider types 84s and 95s for outpatient hospitals. There's a little bit of nuance to that, and so I'm going to ask that if you do have questions, specifically if you represent a hospital and you need more details about the interaction with 84 and 95, you contact our hospital staff if you need that information. If you haven't already talked to them over there, let us know and we can get you their contact. Will TBS workers be allowed to provide counseling? High school plus 3 years is an allowable criteria to provide counseling. They're allowed to provide services as defined in the rule and in the state plan. Right now, our rule 5160-2708 outlines all the services that they can provide, and it matches our state plan that is with CMS right now. Psychotherapy in regards to place of service 99, all of the allowable places of service for each codes are in the manual, and I don't believe that 99 is an allowable place of service for psychotherapy. There are places like home, office, homeless shelter, etc. So if you look there, you'll see all the allowable places of service. QMH plus 3 and the rate. The QMH plus 3 makes the bachelor's rate for providing TBS, but they have their own separate rate for mental health day treatment, and this has not changed. In the per diem model for mental health day treatment, clients must be present the entire 2.5 hours to bill, or is that half the amount of time, 67 minutes? 2.5 hours is the half of the time. The service was built on a 5-hour service, so 2.5 is the minimum because that is the half amount of time. Sorry, these fonts are a little small, so hold on one second. All right. So that I'm going to continue on, and the questions will keep coming in, but we'll answer them at the next break. But I'm going to keep moving now. Okay. H2017 and H2019 different uses. So as we've gone through this whole process, we had to adjust our coding in order to fit the actual practice in community behavioral health. And because of that, we've actually used H2017 and H2019 in a few different ways. So I wanted to have a chance to walk through all of them, make sure that everyone's on the same page, and so you could have this as a resource. So the first way that it's used is the traditional way, the definition of the code. H2019 is defined as therapeutic behavioral services, and H2017 is psychosocial rehabilitation. TBS and PSR are defined in the Medicaid rules 5160-2708. They're at the Register of Ohio right now, or being filed with JCAR. TBS are defined as goal-directed supports and solution-focused interventions intended to achieve identified goals or objectives as set forth in the individual's treatment plan. And then psychosocial rehab assists individuals with implementing interventions that are outlined on the treatment plan to compensate for or eliminate functional deficits and interpersonal and or behavioral health barriers associated with that individual's behavioral health diagnosis. Both of these services are provided by unlicensed mental health practitioners, and all of those qualifications are found in the rule. So if you look here on the other side, it talks about all the permutations of that. We have office rates, and we have community and home rates. The home and community rates are a little higher. And then we also have bachelor's rates, master's rates, and then we also allow QMHSs plus 3 years of experience to provide TBS. If you look below, psychosocial rehab is going to be less than a bachelor's degree, less than that 3 years of experience, and we have an office and home and community rate for that as well. Okay, so the next way that we have used H2019 and H2017 is for crisis billing. So originally we had the psychotherapy for crisis CPT code, but we did not have any ability for unlicensed practitioners to provide and bill for a crisis service. So we have decided that H2019 and H2017 on the mental health side could be used, and we just ask that you add the UT modifier to indicate that it is a crisis. So this is for unlicensed practitioners, and unlicensed practitioners can only bill Medicaid for crisis if the recipient is known to the system and is currently carried on the unlicensed practitioner's caseload, and a licensed practitioner has recommended care. And if you look down below, you'll see that this has the same billing permutations as regular TBS and PSR. Master's rate, bachelor's rate, QMHS, home and community versus office. So then we have registered nurse, and we're going to talk about nursing services in just a few slides, but a registered nurse providing nursing services to patient in crisis also needed some way to be billed. So what we've done is we've taken the RN code H2019, add the UT modifier on to indicate that it is a crisis, and it's billed the same way with the nursing MPI, the RN MPI, and then home and community versus office place of service. So then we get into nursing services. So originally when you go through nursing services, the only evaluation and management code that a nurse can provide is H99211, which is a pretty short office visit code. So we knew and were told by stakeholders that there was a lot more that RNs and LPNs were being utilized for in community behavioral health. So we have added codes to accommodate that. So on the mental health side, RNs are using H2019 and LPNs are using H2017. And then we're going to move into nursing scope of practice for RNs and LPNs. So as we've gone along this whole process, we get a lot of questions about particular codes and particular service if they are in the scope of a RN or an LPN. Medicaid is not the determiner of scope, nor can we tell people whether or not things are within scope or not. We are not the experts on that. So what we've decided to do is, as we should, is rely on the knowledge of the Ohio Board of Nursing. They provide guidance on nursing scope at that link. And then in addition, if you have particular questions about scope of practice that may be more nuanced to your agency, they do have an email address, practice@nursing.ohio.gov, where they can help you determine if a service is within scope of an RN or an LPN. So for Medicaid billing purposes, any service activity that falls within their professional scope can be billed under that H2019 or H2017 on mental health, or T1002, T1003 on the SUD side, and I'll show those in just a second. So just to note that the scopes for RN and LPN are very different. They're not interchangeable, so make sure that you are aware of the difference. And then lastly, each licensee is responsible for knowing and working within their scope of practice, as well as the physician who is supervising or ordering a service. It is their responsibility to know what they are allowed to do as an RN or an LPN. So rely on your licensees and the Board of Nursing to help determine that. So to that end, these are all of the codes that an RN or an LPN could bill in community behavioral health. So if you look on the SUD side, we have T1002 for the RN, T1003 for the LPN. H0014 is ambulatory detox, that's RN and LPN. And then H0048 is that urine drug screening. Codes that are shared on the SUD and mental health side is 99211. That's that short, about 5-minute office space evaluation and management service for established patients. 96372 is an injection code. And then on the mental health side, we have H2019 for RN services and H2017 for LPN services. Just a reminder that these are two of the practitioners that do need to enroll in Ohio Medicaid and will need to use their rendering MPI on the claim. So just as a reminder, this slide's slightly out of place, but I think Doug was mentioning this earlier, that the TBS and PSR services rendered in the office or in the community mental health center, place of service 11 or 53, will be 50% after 90 minutes of that service. But all other places of service in the community, in the home, etc., will be paid at 100% after 90 minutes. Okay. Keep going? Should I keep going?
If you want to pick up, it's up to you.
Okay.
Okay.
Okay. All right. So you can keep typing in your questions and we will address all of them at some point. But I'm going to keep moving along till we make sure we get everything covered and recorded. So the next thing I'm going to talk about is crisis services. So in about 2012, the CPT code added a new code called Psychotherapy for Crisis, 90839, and the 90840 is an add-on for when a crisis goes beyond 30 minutes. It's each additional 30 minutes. So the definition of this service is an urgent assessment and history of a crisis state, a mental status exam, and a disposition. The treatment of that includes psychotherapy, mobilization of resources to diffuse the crisis and restore safety, and implementation of psychotherapeutic interventions to minimize the potential for psychological trauma. The presenting problem is typically life-threatening or complex and requires immediate attention to a patient in high distress. So, we have the presenting problem. Like we said, it's typically life-threatening, it's complex, it requires immediate attention. And so that service part of the presenting problem includes urgent assessment and history of a crisis state, mental status exam, and a disposition. And then when we move to treatment, it includes things like psychotherapy, mobilization of resources, and implementation of psychotherapeutic interventions. Because all of those things are included in the psychotherapy for crisis service, there are codes that the AMA guidance and CPT doesn't allow to be billed on the same day as psychotherapy for crisis. So that's 907, 91, and 92, your diagnostic evaluation, your psychotherapy, and interactive complexity, as all crisis situations are inherently interactively complex. So when we get to the actual coding for crisis services, you have 90839 psychotherapy for crisis, which is the first 60 minutes, 90840 is each additional 30 minutes. It's used to report the total duration of face-to-face time with the patient and or the family providing psychotherapy for crisis. Time does not have to be continuous, but it must occur on the same day. And provider must devote full attention to the patient and cannot provide services to other patients during the time period. So this is saying that if you are providing psychotherapy for crisis, someone is in crisis, they are escalated, the time that you can bill psychotherapy for crisis is when you are face-to-face working with that patient. If for some reason something calls you have to step out, that is fine, or if you need to have them go see something else, that's fine, but you can't bill psychotherapy for crisis for the time that you're not spending face-to-face with the patient. But as you said, it does not have to be continuous, just on the same day. So you report 90839 for the first 30 to 74 minutes because of that law of halves. It's only reported once per day, and then 90840 for each additional 30 minutes. So it's beyond 74 minutes is your first 30 minutes, and then again. So if you're doing 120 minutes of crisis psychotherapy, you would do 1 90839 and 2 90840s. Less than 30 minutes. So if you for some reason have a crisis that does not last a full 30 minutes, you can't bill 90839. Medicare, and we have adopted this policy, allows you to use 90832, which is that psychotherapy 30-minute code. We just ask that you put on the UT modifier so that we know it was a crisis situation. And I just want to emphasize that the code psychotherapy for crisis is to be used for the time that that person is actually in a heightened state. They are in crisis. It is not a multiple day thing where they're escalated and then you de-escalate them and then you work on finding them a bed, or they are de-escalated and then all of a sudden they get a checkup. All of the things outside of that are billed separately, are provided separately. This is only to be used for the time that the patient is in crisis. So for this code, it's shared by mental health and SUD. It's provided by licensed practitioners, and that is because this can be provided to people who, whether or not the individual is on their caseload or whether or not the individual is a current patient with the agency. And because this service includes a brief assessment and a mental status exam and a disposition, you have to start planning your treatment immediately. It is only within the scope of practice of a licensed practitioner to be able to provide this service. So you'll see here the codes we've already went over, 90839, 90840, and 90832. Now when it comes to unlicensed practitioners, we already talked briefly about the mental health side. But for the SUD side, we also have a coding option. So it's H0004 UT modifier, and that's to differentiate that it's a crisis service and not just simply a non-crisis individual counseling. And then on the mental health side, H2019 and H2017. The practitioners that can provide it are the same as can provide the regular H0004, H2019, H2017. So just make sure that you're familiar with who can provide this service. Okay, and then we also talked briefly about this RN nursing services. So RN nursing services delivered to a patient in crisis. We have H2019 on the mental health side with the UT modifier and T1002 on the SUD side with the UT modifier. T1002 is that RN nursing code on the SUD side. All right, so I'm going to turn it over to Doug to talk about the substance use disorder benefit.
All right, before we do that, let's do a couple of the questions again. Okay. If providing MST or FFT currently, can these services continue a la carte if not IHBT certified? Because we actually do not recognize MST and FFT directly, we don't have a rate for it. If you are an MST or FFT team and you want to become IHBT, you certainly may do that. Or if you just want to treat it as individual practitioner services, you certainly may do that also. Can a licensed practitioner provide TBS, therapeutic behavioral services? The answer is no. Therapeutic behavioral services is for a higher level qualified QMHS trained other individuals with the education background. It is not for licensed practitioners. The acceptable location codes for each of the services, if you get a copy of the manual, the current one I believe is dated May 9th. In that it has tables for all of the codes, and the place of service, allowable place of services codes are at the tail end of each of those tables. Let's see, TBS and PSR be provided in a residential or group home setting. I believe that on the mental health side, because we don't actually recognize those things, you would actually be using place of service home for that individual at that point in time. LSW providing TBS-like service will be paid. Well, an LSW licensed people should not be billing for therapeutic behavioral services again. It's not a code associated with their practitioner type. Can unlicensed practitioners provide PSR and MH crisis? Practitioners who can use the appropriate coding with a UT modifier may certainly provide those services. So PS, you want to?
Yeah, I want to have a brief mention of the workbook. We're posting a new version today. The version that we posted last time got wonky and some of the links were broken. We have not changed our policy on who can provide PSR and mental health crisis. It's the people who can provide the individual codes. So PSR is less than a bachelor's, less than that 3 years of experience, and then mental health crisis being billed under H2017 would have to meet those same criteria. So if you look at the code chart, I understand that some of the trainee and assistant codes, those cells got a little messed up, but if you look all the way over at the QMHS, you'll see that it's a QMHS associate, it's a QMHS high school that can provide PSR.
So to keep us on track, we'll go ahead and jump back into the presentation. We will keep the log of all the questions from the webinar. So if we actually don't get your question answered today verbally, we'll see what we can do about posting those up. But for the SUD side of the house, the component of the benefit, here's what it looks like today. So everybody should be very familiar with this. For SUD, it does cover residential and outpatient services today. But for all intents and purposes, it looks the same with the exception of, you can see down there on the bottom left, methadone administration is generally treated as an outpatient component of the service, even if the individual is in a residential setting, because the medication goes with them to a certain degree. So we've been talking about the American Society of Addiction Medicine levels of care. We've used this visual a number of times. So the green arrow is what indicates the levels of care that are covered in the Redesign benefit package. We do not address the 0.5 level, which is early intervention. That's pre-diagnosis, pre-treatment. That would have to be addressed a little differently under the coverage options. We also do not address 4 in the community benefit. That level of care 4 is a hospital service that would be covered through an inpatient hospital setting, not a community SUD treatment program, if you will. So here's what our new benefit looks like when we marry it with the ASAM levels of care. You can see we cover the 4. The 3 outpatient levels, which is general outpatient, intensive outpatient, and partial hospitalization. And then we have our residential level of care all the way there on the far right. For all intents and purposes, all the outpatient levels of care look the same. All the services are available. There's no adding or taking them out except for what we've got boxed down here at the bottom, which is where we've put in coding for longer duration group counseling and psychotherapy. We'll talk about that in a little bit. You can also see the withdrawal management. Level 1 withdrawal management, it's just billed as the combination of medical services. Those are individuals that are just having a certain low level of medical monitoring through their withdrawal. And then at level 2, Cicely mentioned this, we brought online the H0014 code, which is for the RNs and LPNs when there is more extensive on-site medical monitoring by those practitioners under the direction of a physician or a higher level practitioner. And then we have our residential, which we have per diems, which cover all 6 residential levels of care. The clinically managed through medically monitored, there's 4 levels of care there. And then the 2 residential levels of care for withdrawal management. And then you'll see the little box down there at the bottom that residential programs also can do. They have another withdrawal management code down there. That's for individuals that they may be having extended on-site for observation and monitoring to determine whether they should stay in residential or they may be successfully treated at one of the outpatient levels of care. So I won't read through all of these, but here is the cohort of medical service coding that we have available. Mary covered the mental health ones. This is exactly the same cohort of codes. Here for our higher level medical practitioners, the evaluation and management office, new and established, home, new and established patients, and then the add-on codes that are there, and then the therapeutic injection code. So we've added a couple of slides here in this next section. So let's touch on SUD group counseling for individuals who are at level of care 1. So that's adults who are less than 9 hours per week of services and adolescents that are less than 6 hours. So to accommodate that the bulk of what occurs at these levels of care oftentimes is group, we have the 90853 code that is available. If the service is 52 minutes or less, you should use the 90853. And it pays at $21.63 per encounter for licensed practitioners and $25.45 if you happen to have the physician providing the service, and that's based upon the general payment scales for CPT coding. So then to accommodate longer duration groups here, we have added the H0005 with the HK modifier for licensed practitioners, and the H0005 with the AF modifier, which is for physicians, medical practitioners. You have to exceed the 53 minutes to get into using these codes, otherwise you would use the 90853. It's billed in 15-minute units, so you will not use this if the units is less than 4. Keep that in mind because you have to at least hit the 53 minutes. And then you need to make sure you report the appropriate increments of minutes based upon the duration the service is provided. So this can get a little odd, so we put this together and we've used this slide before, but we've expanded this section a little bit. So for our 6 patients here who are seeing me, I happen to be the group leader for this day, and what I'm doing is providing group counseling across a 3-hour time frame here. So our first person is here for all 3 hours, so we would bill 8005 HK with 12 units to represent that 3 hours. Same thing with our second patient. So in the middle, now we have an individual who was here for the first hour and the third hour. Those still combine, 80005 HK with the 8 units to represent the 2 hours of services. Same thing holds true for our fourth and fifth patients. They just happened to one have been there for the first 2 hours, and then the second one happened to be there for the second 2 hours. And then our last person, for whatever reason, they arrived late, left early for group 2, or just something occurred and they had to leave early. So we have the example of the 90853 because they were only there for 45 minutes. All right. So we've had discussions on our trainings about co-facilitating and how things are coded. People will come up and ask us, does it go to Doug? Does it go to Cicely in this case? Or how do we do this? A lot of that is up to you as an agency. If you're applying some level of productivity standard internally, that may inform how you do this. But we're showing you the options that are here. And it gets a little more complex, because we've upped the number of patients because now we have 2 facilitators. So our first 3 folks here that are there for all 3 hours, if they were attributed to me as the LICDC, each one would be coded H0005 HK with the 12 units. If they're attributed to Cicely for billing purposes, all of them, all 3 of them, it could be H005 with the 12 units. So it just begins to give you the examples of how you can code these depending on co-facilitation and internal agency policy on how you want to do this. Just keep in mind you cannot attribute a patient to more than one of us, so Cicely doesn't get credit and I get credit for the same person. So we're just kind of showing, depending on how you decide to do this, there's a lot of coding options that could result. So these are some new slides here too for level of care 2, intensive outpatient and partial levels of care. I got some in here. I will not read through this. We've been using this slide probably for a good year and a half. Some of our examples that we did in the one training where we went through examples for about a good hour. But you can see this, and this is an individual who's getting 16 hours of services recommended during the week. For our purposes, we assume that they attended all of them, but they may not. That happens. So as a reminder, what we did for these levels of care is we brought or kept the H0015 code. And for the IOP level of care, we assumed a group size of 3 for an average of 4 hours for our rate setting purposes. Keep in mind what we did up above the blue line is what we did to establish the rate. Below the blue line is billing guidance and practice guidance. So maximum group size of 1 to 12. You only use this, the H0015 or H0015 with the HK for the IOP level of care. I'll talk in a minute about the partial level of care. People need to be there for the minimum of 2 hours and 1 minute, technically, the halfway point of our 4 hours for rate setting purposes. If they're not, H0005 or 90853 may be used. Because this is a per diem, it is billed in a whole unit only. All other services are billed in addition to this or outside of it, however you can make that work in your mind. So if the person has group and individual on the same day, the individual is billed separately. It's no longer covered under the whole umbrella. And because this is a per diem code, you only get 1 per diem per patient per day. So our next 2 slides will look a little familiar, but we broke apart the, and wanted to give an example. We are assuming that all 6 folks here are at the IOP level of care. So that's why you see the H0015. The first 2, because they're there for the 3 hours, they certainly make the halfway point. Our third person here, and fourth and fifth, we're assuming that they made the 2 hour and 1 minute to get to being able to use the per diem code. And then again, our last person, our 6th one here, came a little late or had to leave a little early, and they only got the 45 minutes, so that's why you see the 90853. Keep in mind that this is just an example of the IOP variations. We are assuming that all of these patients are at that level of care, but it doesn't require you to put them all in the same group. So here's our co-facilitations version. It's very similar to the first one again. And it shows you the possible coding. And now because we have 6, 12, 13, 14, 15 people, we brought Cicely online as our CDCA to keep our ratio of 1 to 12. So we're co-facilitating this whole group of folks. And depending on how we attribute the clients to the group leaders, they could all, H0015 HK are those that are attributed to me. H0015, no HK would be folks that are attributed to Cicely. So again, depending on what you do internally with agency policy, you'll need to decide how you would like to reflect the co-facilitated group in terms of claims. So now we jump up to our partial level of care. So our little yellow sticky in the top right, refer you back to slide 9, policy update number 3, which has to do with being able to bill additional group on the same day so you can connect these things. But this is the same slide again we've been using. Above the blue line is our rate setting purposes, group size of 3 for average, 6 hours of attendance for rate setting purposes. Set that aside. That's how we got to the 154.56 and the 224.82 for licensed practitioners. Down below, again, the maximum group size, 1 to 12 practitioner to client ratio. So anytime you have 13 people, you need at least 2 practitioners. This coding with the TG, the H0015 with the TG, is what is used to represent individuals who are at the partial level of care. If the person doesn't attend for the minimum of 3+ hours, 3 hours and 1 minute, and that's because we base the rate setting on the 6 hours, you can use the H0015 without the TG as long as they meet the 2 hours and 1 minute, or you can use the H0005 or 90853. So there's options to be able to bill the actual amount of time the person attends. Again, because this only represents group counseling, group psychotherapy, all services are billed in addition. So that would be things like individual SUD case management, family psychotherapy if you're providing that, medical services, those are outside. They are not covered under the umbrella IOP. You have to have a licensed practitioner to bill with the HK, and again, because this is a per diem, 1 per patient per day. So we've inserted these slides again. Our variation here, you'll see patients 1 and 2 because they're there for the 3 hours and 1 minute. They have the H0015 HKTG, licensed practitioner. This is just Doug with this group of 6. Our 3rd, 4th, and 5th, you can see they did not attend the 3 hours and 1 minute. So we can't use the TG, but we can use the H0015. And then our 6th individual, again, they came early or came late or left early, pardon me. So we use the 90853. So here again is our co-facilitated group that you can see now that we have Doug and Cicely because we have our 15 people. For whatever reason, I can't keep that straight. Again, depending on which clinician we attribute the patient to, it determines how the claim is coded. Keeping in mind, you cannot attribute the same person to both of us. So you can see how complex that might get depending on your internal policies and how you want to assign a claim to practitioners. So we'll touch real quickly on the residential. Tie this one back to the policy slide, slide 8, policy update number 2 that we covered earlier. ASAM is a national model for individualized assessment and outcome-driven care. The ASAM criteria is the clinical guide for both Ohio MHAS certification and the Medicaid SUD benefit package, the non-hospital package. Additional information on it is now covered in the Ohio Department of Medicaid Rule 5160-2709. That's the one that will be updated to take the staffing out. Cicely mentioned it's been updated in case you haven't heard her. Again, I think she mentioned earlier you can get that off the Register of Ohio website. Because an individual is in residential care, residential programs are expected to provide comprehensive SUD biomedical and co-occurring services to residents as they need. And each per diem rate is based on this assumption because it's based on practitioners to patients, including practitioners that can provide services for both mental health and SUD conditions, if you will. Administration of Medicaid by the staff of the residential program is covered within the per diem, but the medication itself may be billed in addition to the per diem. If medication, for whatever reason, needs to be administered by an agency other than the residential treatment program, then the other agency may bill both the administration and the medication cost. Okay. And that's the SUD section. So, are you picking back up with this one, Mary?
Yes.
Okay. So we'll
Just looking at some of the questions. This is Mary. I'm going to cover the next couple of sections. This first section is benefit administration, timeline, policies, and program integrity. This is the timeline. You should be familiar with this. You've seen it many, many times. We have updated it a few times with some nuances. The transition to the new code set will occur on July 1 of 2017. The managed care carve-in will occur in January of 2018. I would point out to those of you who have relationships with MyCare plans, because behavioral health services are carved in currently for MyCare members, they will change, those services will change to the new code set effective July 1 when we move to the new code set. Both the MyCare plans and the traditional managed care plans will maintain fee-for-service rates and fee-for-service policies. The policies will be maintained by MyCare plans for 12 months. The rates will be maintained until December 31st for both MyCare and traditional managed care. And any prior authorizations that are approved by Medicaid prior to carve-in will be honored by the plans, and the plans will assume the responsibility for those prior authorizations when the fee-for-service transition occurs. This is a slide that just reminds you about the responsibility of Ohio Department of Medicaid as a state Medicaid program. We have a statutory requirement under the federal law to perform post-payment reviews and to assure program integrity for the state and federal funds that comprise the Medicaid program. We have in the Department of Medicaid a unit, surveillance, utilization, and review section that takes care of this function for us. They perform regular random samples of Medicaid data to identify any patterns that fall outside of the mean. And so any providers that have outlier patterns may be contacted for post-payment review and possible recoupment of those overpayments. In extreme cases, if there is a suspicion of fraud, waste, or abuse, those cases may be referred to the Attorney General's Medicaid Fraud and Control Unit. Now I'm going to go over the services in the benefit package and cover which of them are prior authorized and under what circumstances they are prior authorized. So the first three here, assertive community treatment, intensive home-based treatment, and SUD partial hospitalization, are always prior authorized before the service can be rendered and paid for. So here is the code for assertive community treatment, H0040, and we'll go over ACT in much greater detail in future slides. This is intensive home-based treatment, the code H2015. It must be prior authorized, and we're setting a maximum of 72 hours or 6 months that can be authorized per PA date span. SUD partial hospitalization is the other service that requires prior authorization before it can be rendered. So anything up to 20 hours does not require prior authorization. When you hit that 20-hour mark, that's when you need to seek prior authorization for SUD partial hospitalization level of care. The next section is services that require prior authorization per billing provider. So the first one is the psychiatric diagnostic evaluation. This is both the with and without medical version of that CPT code. The benefit is 1 encounter per person per calendar year per code per billing provider. So if Doug sees my agency first and then moves to another part of the state and sees Cicely's agency, then Cicely's agency does not need to seek prior authorization for performing a psychiatric diagnostic evaluation. However, if Doug requires a second one of these during the same calendar year from my agency, then I would need to seek prior authorization for that service. This is SBIRT, screening, brief intervention, and referral to treatment. Again, one of each of these codes, they're the same service, just greater length. So if more than one is needed per billing provider, per patient, per calendar year, prior authorization can be requested. And we will talk more about prior authorization a little bit later on in the presentation. So if you can hold on for that, we will go over it in greater detail. And then we're also doing a webinar tomorrow to instruct folks how to use the prior authorization subsystem in MITS so that you can submit those prior authorizations. The final service in this category is alcohol or drug assessment. That's the H0001. You're familiar with that service. It exists today, and it's going to continue on after July 1st. We're setting the prior authorization threshold at 2 hours or 2 units per person per calendar year per billing provider. And this does not count toward the ASAM level of care calculation. So you might want to factor that into your thinking about your ASAM levels of care. The final section here is services that have no prior, with prior authorization per Medicaid enrollee. So this is PA attached to the Medicaid enrollee. The first one is psychological testing. You see the first 3 there, 96101, 96111, and 96116. Have up a PA threshold of up to 12 hours or encounters per calendar year. And then the 96118 neuropsychological testing has a threshold of up to 8 hours per calendar year per Medicaid enrollee. And if your client requires more than that, you can seek prior authorization. And then SUD residential, this is non-withdrawal management. You can see the codes there that are attached to it. Up to 30 consecutive days without PA per Medicaid enrollee. Then PA after the 30th day has to be requested, and in order to extend beyond that first 30 days. This applies to the first 2 stays. Any stays after the first 2 in any calendar year would be subject to prior authorization beginning on day 1. This section is the services that have no state-defined benefit limits. So this is RN and LPN nursing services, therapeutic behavioral service, psychosocial rehab, CPST, psychotherapy, the evaluation and management medical visits, both the office for new and existing patients and the home codes for new and existing patients. SUD withdrawal management. Mental health day treatment, group mental health day treatment. SUD intensive outpatient and outpatient levels of care. This is the up to 19.9 hours of SUD services per week per adolescent and per adult. And for outpatient, it's less than 6 hours for adolescents and less than 9 hours for adults. Crisis services. You can see here crisis services come in a variety of different code sets, some of which are CPT codes that must be performed by licensed clinicians, and then others that can be performed by unlicensed practitioners. And then the codes at the bottom there are the crisis billable codes for RNs when they are responding to patients in crisis. All right, that ends the section on the prior authorization thresholds for the benefit package. The next section is coordination of benefits. We have communicated this to folks a number of times, so this shouldn't be new information. I think many of you have already been working to seek Medicare enrollment for your practitioners who require Medicare enrollment. So you can see on this slide in the gray section, those are the clinicians that must bill to Medicare prior to billing to Medicaid if you were serving an individual who has Medicare coverage. Then the individuals listed in the blue, the practitioners listed in the blue, if they are the treating clinician for the Medicare enrollee, those claims can be submitted directly to Medicaid. This is a slide that just talks about your agency's enrollment with Medicare. You have a couple of options. If your agency is not already enrolled with the Medicare program and you treat Medicare patients, you should be pursuing enrollment of your agency as well as your clinicians in the Medicare program. You have an option to seek Medicare certification or Medicare participation. This slide just simply encourages you to seek Medicare participation as a group practice. It's a little bit quicker, easier, and requires a lot less criteria than does Medicare certification. But in either way, if you are treating a Medicare patient, your agency must be enrolled in the Medicare program. This is a slide that gives a little bit of guidance about third-party liability for commercial plans. We are going to begin July 1 enforcing third-party liability not only for Medicare but also for commercial insurance coverage. If you are serving individuals who have third-party coverage through some kind of commercial plan, you should be aware of this if you are not already. You can find a document on our bh.medicaid.ohio.gov website for the services that are billable to Medicare. That would be the best place to seek advice about which services need to be are likely covered by a third party, by a commercial insurance plan. If you are treating someone who has commercial insurance, you should make sure that you submit that claim. If the code that is being billed is on that list of final services billable to Medicare, and you will need to get a denial code to put on the claim in order to submit your claim to Medicaid and get it paid. And that is the end of my section. I will turn it over to Cicely to talk to you about supervision.
Where are we at? We're going to take a minute and do some questions. We've gotten a lot since the last time, so if you just give us 1 second. Okay. This is me. Cicely stated that psychotherapy is not allowable for place of service 99. The most recent manual indicates that place of service is allowable for psychotherapy. It says that place of service 99 is allowable for 90832 with the UT modifier. So it's allowable when you're using it to represent crisis. But if you look, it doesn't allow it for any of the other psychotherapy codes. There seems to be an inconsistency regarding the pay reduction when operating under general supervision versus direct. The provider manual indicates that the supervisor is not included on the claim because it was not directly supervised. The claim will be paid at 72.25%, but I've heard you say it's 85%. Can you clarify? Yes. So if someone is under general supervision, it means they get 85% of their supervisor's rate. For someone under the general supervision of a licensed person, a licensed independent, that is 72.25% of the Medicaid max. So both are correct. So an LISW makes 85% of the Medicaid max. A social worker trainee under general supervision of an LISW makes 85% of their supervisor, which is 72.25% of the Medicaid max. If a TBS crisis occurs, can other services still be performed or billed for the same day, unlike psychotherapy for crisis? Yes, we don't have any limits on that as a state. Any NCCI edits that exist would still apply, but no, we don't. It doesn't have the same rules as psychotherapy for crisis. Can a licensed therapist conduct and bill for a QMHS group? So no, a licensed therapist cannot act as a QMHS. There are group options, mental health day treatment on the mental health side, and then SUD, IOP, and partial hospitalization, and individual group counseling on the SUD side. So I'm not sure if I answered that question correctly, but a licensed person cannot act as a QMHS. In crisis services, so you say CPST can provide crisis services to a client provided they personally know each other. I think you mean unlicensed staff can perform crisis services to a client that they personally know each other. We don't have anything called a CPST staff. Does this mean staff on the same team cannot provide crisis coverage for each other? What we mean is that the person, if they are unlicensed, has to be briefed on the patient's care. They cannot help someone who is off the street. So if you do a team method, if someone is covering, they need to be brought up to speed on that person's case. They need to have access to their case files. They need to be prepared to treat them because an unlicensed person doesn't have the capacity to assess someone on the fly. So this one's about hospital. Once again, if you have hospital questions, I'm going to refer you to our hospital staff. You can email hospital_policy@medicaid.ohio.gov, and they'll get that immediately and can answer any questions on hospital billing. I know that they also just posted their rate sheet on the website on medicaid.ohio.gov, so you can also look for that there. Can you clarify the meaning of place of service 53 CMHC? Many agencies seem confused whether they are 11 or 53. Well, that's kind of just an agency decision. 11 means office, and 53 means community mental health center. So either one, they're interchangeable if you're a provider type 84, so you can use either one. Yeah, I missed a couple. Can phone calls be billed under TBS or PSR, or is it face-to-face only? It is face-to-face only. All services are face-to-face only unless they're indicated that they are available by phone. So just assume that is face-to-face unless it says otherwise. Will a copy of this presentation be available? Yes, it will be posted. Does an unlicensed psychosocial rehab provider need to enroll with Medicaid if under the supervision? No unlicensed staff needs to be enrolled in Medicaid. We're actually going to talk about, or Mary already talked about?
Yeah.
Mary went through, I think this was asked before she did this. Mary went through all of the ones that need to enroll already, so just refer to those slides. Can you bill crisis services on the same day you bill day treatment? There are no state-defined limits on that. If there's an NCCI edit, obviously that wouldn't be allowed, but we don't have any edits against crisis and day treatment. Is the psychotherapy for crisis available for mental health providers as well as SUD? Yes, it's a shared code. Is there time limitations on crisis therapy? The state doesn't have any defined limits for crisis psychotherapy. However, I believe there is a NCCI edit and MUE currently. I'm going to talk about that in a little bit. So as long as that is still there, there will be a limitation placed by CMS and the AMA. H0048, urine testing and handling listed in the rule as not in residential setting. Does this apply to recovery house or sober living facilities and clients' homes? Residential facility, in the purpose of that rule, is referring to a substance use disorder residential treatment facility. That means that we will not separately reimburse for urine drug screen when someone is in a residential treatment because that's already included in the per diem rate. So all other allowable places of service for H0048 are found in the manual. Can mental health day treatment per diem be provided in a client's home or as a residential group setting? Once again, all allowable places of service are found in the manual.
Next question is, are agencies required to be certified in crisis services through Ohio MHAS in order to bill any crisis service? We have made some parallel rule changes on the MHAS side. Some are related to redesign. Some are finalizing the merger of ODATIS and ODMH. And yes, there is still a crisis certification rule out there that you will need to be certified under.
Okay, this is about who can provide case management and CPST in the Excel workbook. As I said earlier, the trainees and assistant cells got a little messed up, but once you get down, and we will post a new one, but once you get down to CPST, TBS, PSR, case management, they're operating under the their bachelor's or their master's degree, not necessarily their intern trainee. So if you look over and it says QMHS plus bachelor's, if your social worker trainee has a bachelor's, they can provide it. So we will fix the manual, but it's the same. We have not changed that policy on who can provide those services. CMS may do urine collection and handling, but not a QMHS, even though this is now available for mental health day treatment. No, urine drugs collection and handling is only available on the SUD side, and a QMHS is only on the mental health side. So that's correct. The workbook is correct. They cannot provide H0048. What other services can be billed on an IOP day? So you'll need to look at the rule. We just went through all of the IOP thing. The IOP per diem only includes group services. And now we've adjusted our policy to allow additional group services outside of it. So you can have all your individual services, all your medical services, and now some group services as well can be billed on the same day as an IOP day. It's not the same as it is now. If someone attends IOP for 2 days in a week and then misses a day due to illness, can IOP be billed for all 3 days? No, you only bill IOP for the days that they actually attended the IOP group. It doesn't mean that they are not in the IOP level of care if for some reason they miss a day, but you can't bill for the day that they miss. We already answered the crisis intervention. Hold on, I'm reading, so it takes me a second. So for, this is asking about our limit for psychiatric diagnostic evaluation. They are asking, we concerned with the 1 session limit on assessments. Currently, we often take 2 sessions for an assessment with children. You have a few options with that. 90791 is psychiatric diagnostic evaluation. I'm saying that because this is different than just an assessment. It's not the same service. They're not equivocal. So that is it's an encounter code. You get it for as long as it takes. So your option is to either just bill it for once for as long as it takes you to get all the information you need. Your other option is to request prior authorization for an additional unit of 90791 if you know it's medically necessary for it to take multiple times. And your third option is to complete what you need in a psychiatric diagnostic evaluation, bill it as 90791, and then as you're continuing to treat that patient, you can still get more information as your psychotherapy sessions or your counseling sessions continue. But 90791 is intended to cover a full psychiatric diagnostic evaluation, and it is generally not medically necessary for someone to have multiple psychiatric diagnostic evaluations in a year. Okay, yes. So if providing both mental health and SUD services, example, mental health psychotherapy and SUD case management, are these billed separately under the appropriate mental health and SUD services? Yes. So for Ohio Medicaid, you're seen as separate providers, even if you're under the same roof or you are a dual agency, or if the patient is has both a mental health and an SUD disorder. So you'll bill your mental health services under your mental health provider type 84 and your SUD services under your provider type 95. The copy of the manuals is on bh.medicaid.ohio.gov/manual. Are there time limitations for crisis psychotherapy? Just if applied by NCCI. Okay, so this is asking about hospital services again on the UB. So if you have any questions about how to bill on a UB, reach out to our hospital folks. So regarding TBS, can a practitioner who has associate's degree and has more than 3 years of experience be qualified as a QMHS plus 3 years of experience? Yes. If a client is new to us, receives a crisis psychotherapy service, and our crisis assessment includes all the items required in the brief assessment and treatment plan, can services then be provided CPST, PSR, TBS until they get their comprehensive assessment and full treatment plan? I believe the answer is yes. I'm a little unsure about providing a specific answer because I'm not sure exactly what the question is asking, but I think what you're referring to are the services that cannot be provided on the same day as crisis psychotherapy. So once the patient is been de-escalated, then yes, other services can be provided, such as CPST, TBS, and PSR. Okay.
All right. We're going to give Cicely a break here for a minute. We are just, we could probably stand here, sit here. Y'all can't see us, but run questions throughout the day. We're not even making a whole lot of headway. So if people would humor us, give us about 5 minutes to take a break in the room, then we're going to get back on the presentation, and we'll come back to the questions as we can. Thank you.
Hello, everyone. All right, so we've done a very brief break. I'm going to jump in to the supervision requirements section. We'll tackle some more questions later, but once again, we want to make sure we get everything recorded and don't make y'all sit here till 5 o'clock tonight. Okay. All right, so we have two types of supervision. There is general supervision, where the supervising practitioner must be available by telephone to provide assistance and direction if needed. And then there's direct supervision, which is the supervising practitioner must be immediately available and interruptible to provide assistance and direction throughout the performance of the procedure. However, he or she does not need to be present in the room when the procedure is performed. So when we get to minimum supervision requirements, for CPT codes, it is all general, from your licensed professional counselor down to your trainees and assistants. This is a policy update that Doug was talking about earlier. So because we changed our policy and we had some practitioners that were prepared and were already operating under direct supervision, we did not want to kind of hinder the work that they had already done. So now we have this optional direct supervision for those of you who would like to use it. This means that if they are operating under that direct supervision definition and they're providing CPT codes for psychology assistants, interns, trainees, CDCAs, counselor trainees, social worker trainees, and marriage and family therapist trainees, they can also bill under direct supervision. And that means that the supervisor NPI does have to be on the claim, and then they make 100% of their supervisor rate. So I'll go into an example of that. So here's an example of the same practitioner providing the same service, just under different levels of supervision. So for general supervision, a social worker trainee conducts a psychotherapy session with a patient with their supervising practitioner, an LISW, available by phone. The claim is going to be submitted with the U9 modifier that represents that social worker trainee credential. The rendering field will be blank. The billing field will contain the agency's MPI, and the supervisor field will be blank. MITS is going to adjudicate the claim using the social worker trainee rate, which is 85% of their supervisor's rate. So then, if they were operating under direct supervision, which means a social worker trainee conducts a psychotherapy session with a patient, and their supervisor, an LISW, is immediately available and interruptible if the social worker trainee needs direction while providing the session. The claim will be submitted with the U9 modifier again that represents the social worker trainee credential, with the supervisor's NPI in the supervisor field. This allows us to be able to pay at the supervisor rate. Without that, we have no way of paying at that rate. So the rendering field will then be blank again. The billing field will contain the agency's MPI. The supervisor is taking responsibility for the service, and MITS will adjudicate the claim using the LISW rate. So the same, this has not changed. The supervisory requirements for HCPC codes is general. Because it's always been general, and it's already within their scope, there are no direct supervision options for HCPC codes. So a social worker trainee provides psychosocial rehabilitation to a patient with their homes, with their supervising practitioner available by phone. The claim will be submitted with the U9 modifier. The rendering field will be blank. The billing field will contain the agency's MPI, and the MITS is going to adjudicate the claim using the social worker trainee rate. Okay, so when we get down to it, reporting the supervisor on the claim, I wanted to take a second to make sure everybody understood how that is done. I'm skipping that slide. So let's ignore the slide previously because that is no longer accurate. So when you're reporting the supervisor on the claim, you're only going to report the supervisor on the claim if it's under direct supervision. This is the only time you should do that because that is the only time that we will be paying at the supervisor rate. Once a supervisor's MPI is in the claim, that indicates to us that we should pay off of that MPI, but it also indicates to us that they were under direct supervision. So if they were not operating under direct supervision and your medical record doesn't reflect that they were under direct supervision, do not put the MPI of the supervisor on the claim. In more specifics, you're going to report the supervising practitioner at the header level only, loop 2310D. Do not report the supervisor at the detail level, loop 2420D. You're going to need to report only one supervisor per claim at the header, because and then any detail lines under this header must have been directly supervised by this supervisor. And then on this claim, only report supervisors that are directly supervised by this practitioner. So that means that what you're going to do is, if you have John Smith, LISW, you're going to put his MPI in the header, and then every service that John Smith, LISW directly supervised are going to go at the detail line. Do not put any services that were supervised by a different LISW, and do not put any services that do not require direct supervision or were not provided under direct supervision. So here is an example of how to report this on the claim. So you see here, you have the supervisor MPI at the supervisor level, at the header level, no rendering, billing provider had the agency MPI. Then we get down here. You see that the modifier is U9, which means social worker trainee, and they provided psychotherapy for crisis add-on, and then I'm assuming a different social worker trainee it's a different date of service. Sorry. So then that social worker trainee on a different date of service provided psychotherapy for crisis. This means that U9 was always directly supervised by that supervisor MPI in the header. Do not report it this way. This is our big red X, incorrect reporting of a supervisor. So this means you put the supervisor MPI in the header, but underneath you put the correctly supervised ones under the U9, 1, 2, 3, but then on 4, you put a service that was provided by an LISW, which does not require direct supervision, and an RN, which does not require direct supervision, and this will cause this claim to not pay properly. Okay, so just to reiterate, you'll have to do a different header, a different claim for every different supervisor, and only report direct supervision. Do not report a supervisor for general supervision, because it will pay based on direct supervision, but your medical record will not match that payment, and it could result in having to recoup that payment. Okay. So when we talk about practitioner enrollment, just a reminder, these are all of the practitioners that we pay for in behavioral health, for community behavioral health. However, these are the ones that have to enroll. It's their physicians, your CNS, your CNP, physician assistant, RN, LPN, LISW, LPCC, LIMFT, LICDCs, and licensed psychologists. All of those practitioners need to be enrolled in Ohio Medicaid and then affiliated with your agency. They do not need to re-enroll as another physician. They just need to be enrolled and then affiliated with your agency. Physicians, all these ones can be affiliated with multiple agencies at the same time. There's a link to the MIDSPITS that tells you how to enroll and how to affiliate. So we always have this conversation. If they are not enrolled, how do they bill? So they're going to bill with a modifier, and you can see those options here. So a licensed professional counselor, every time they provide a service, they're going to use the U2 modifier to represent that they're an LPC. So this table was pulled right from the manual. It's been there, so this is how you know how these practitioners should bill. And then in addition, if any of these need to be combined or included with another modifier, you'll find that in the manual in this individual charts. So for example, some of them require both the U modifier plus one of the H modifiers to indicate an education level. A good example of that is a social worker trainee may be a bachelor's level or a master's level. So when you're billing, you're going to have to indicate which level they are for TBS. So just look at the manual, look at the charts to know which modifiers are required. Okay, so we have been, our staff here has been working on through any remaining backlog to prepare for July 1st. They've been working overtime to make sure that all these practitioners are enrolled. As of May 15th, we've had 175 agencies with no affiliated practitioners. We put remittance advice for all 84s and 95s. We sent out admits bits, and we have a report of all the agencies without any affiliated. We have a report of the affiliated practitioners by agency on our website at this link. We've had some questions about this when you're reading it. Make sure you find your agency name and then look below your agency name to see your 84 and the enrollments and the 95s and the enrollments. It's not the number above your agency name, it's the number below your agency name. So I would recommend that everybody go look at that report, find your agency, and see how many are affiliated. As I said, as of now, 175 agencies have no affiliated practitioners. If they're not enrolled and affiliated by July 1, their claims will deny. So right now, as far as enrollment status as of May 10th, I'm not going to go through this entire chart, but you can take a look at it. It shows how many we have enrolled. Like we have, for example, we have 2,059 LISWs, provider type 37, enrolled. We have 12 in submit status, which means they have not been touched by Medicaid. And then we have 115 as of 2/27/2017 that were returned to provider that need more information. So make sure you're monitoring your inbox. If Medicaid has to return to provider and ask for more information or for clarification, please reply to that as soon as possible so we can make sure all these enrollments are processed for July 1. So I'm going to turn it over to Mary Haller.
So shall we do these few slides and then maybe respond to questions before lunch?
Sounds like a good idea.
Okay. So there's just a few slides here in my section, and then after I finish, we'll try and get through some of these questions. So I had said earlier that for any services that require prior authorization, you will be submitting those PA requests to MITS. And MITS already has a PA subsystem. You may not be familiar with it because you have not had to use it before now. Tomorrow we will be doing a webinar covering in great detail how to enter the MITS subsystem and how to enter in a prior authorization request and then upload documentation. This is, there are links on this slide that give you information about the existing PA training that is posted on the website. That's the PA functionality overview. And then there is also a webinar from previously. However, the webinar for tomorrow is going to be tailor-made for BH providers. You can go to our bh.medicaid.ohio.gov website and register for that training. And it will be held tomorrow by webinar between 1 and 3 in the afternoon. And there is the link to register for that webinar. We will be covering, we'll be focusing on ACT, IHBT, and SUD partial hospitalization because those are the services that will have to be prior authorized first since they require upfront PA before the service can be provided. So that's tomorrow. Okay, so let's take a break here and respond to some questions. I have no idea where we are. Okay. Why don't you take this one, Cicely? Sorry. Am I on it?
No, I just got to get a little closer.
No, me and
All right. So regarding the change to the tiered rates, if a service exceeds 90 minutes and some of the place of service is community and some of is office-based, will the whole time beyond 90 minutes be paid at 50% or will all be paid at 100%? Neither. 90 minutes in place of service, over 90 minutes in place of service office will be stepped on. 90 minutes in place of service community will not. So it's going to probably hit differently. We'll confirm that. But yeah, it's probably going to hit separately. What are the weekly maximum number of hours for partial hospitalization? So there are no maximum hours. Partial hospitalization level of care for SUD means that someone needs 20 or more hours of services per week. May a nurse do a health history prior to an MD or CNP first appointment without an order? RNs and LPNs cannot bill anything without a physician order. Can CPST multiple sessions be documented on same document? I'm a little unsure what the question means, but I would just refer you to our rules. 5160.805 lines out our documentation requirements. So I would refer you there for documentation. Can an RN or an LPN provide 96372 for therapeutic injection when a patient sees the psychiatrist for an E&M service on the same day in the office? I don't want to speak out of turn, so let me double check on that one. If an adult client is in an IOP level of care and only comes 2 days for 3 hours, is it billed as H0005 or H0015 if a client did not meet the minimum 9 hours? So if they are truly in the IOP level of care, you would bill it as IOP. We understand that sometimes a patient is going to miss services or things are going to come up where they have to cancel, and that is totally fine. It's just that if it becomes a pattern where you may need to adjust their level of care or adjust your billing as needed, when you bill H0015 to us, you are telling us that they are in the IOP level of care, and that is accurate even if they miss an appointment once in a while. Okay. Keep going. So for SUD group, if you co-facilitate a group of 18 patients, can you bill all 18 to a single therapist, or can you bill only 12? So you can bill all 18 to a single therapist. You would bill to the person with the highest credential in the room. However, if you are seeing 18 patients, it is required to then have 2 staff members co-facilitating that group because the maximum group size is 1 to 12. On the new diagnosis grouping documentation, gambling is only listed as a mental health. In the past, there have been different diagnoses available as it is frequently connected to the SUD co-occurring issue. Our diagnosis groups show the primary diagnoses that are allowable. Multiple diagnoses can be reported on a claim, but gambling is not a primary diagnosis for SUD. Okay. So do we use H005 if the minutes are 54 to 60 minutes, and then 90853 if it is less than 53 minutes? Yes. So you would use 90853 if it's less than an hour, and then once you get above that, you can use H0005.
Apologize if we're making noise. We're handing the microphone around. So if we attribute all of the members of an IOP group to the higher credentialed staff or co-facilitated group, does that impact the ratio? We have reiterated, and Cicely just said that, again, that anytime you have 13 patients, you have to have 2 clinicians. So that goes for every sequence of 12. So 13 requires 2 clinicians, 25 would require 3. You know, at that point, you're getting into very large groups, so you might not want to do that and use your staff a little differently. Group size, then you have a go. Yep, same question. If we maintain 12 to 1, can all clients? That's the same question. Clients in 2. Can an agency have clients in different levels of care in the same group? Yes, you may put patients in different levels of care in any group that they would benefit from. Can case management or individual counseling be billed with H0015? I'm assuming you mean the case management service or individual counseling or individual psychotherapy coded separately and billed on the same day as H0015. That is correct. If you're asking if you can put those in the H0015, you would not do that. Day treatment and SUD-PH. We'll skip that. That's a managed care plan one. Yeah, we'll keep doing. Do both of these require SUD residential, acute detox, or outpatient in the residential setting, which I covered earlier? Do they require an MD or nurse practitioner note every day for them to be billed under the MD or NP? Some level of interaction would need to occur with those practitioners in order for them to be reported as the actual rendering. H0014, ambulatory detox, that's the registered nurse or licensed practical nurse. Do they require MD or NP sign-off? We don't require that in terms of note, but they do have to operate under a physician order, as Cicely has mentioned a couple of times. In 90839 and 90840, those are the crisis psychotherapy coding. Is the time spent in arranging a disposition for the patient included in the billable time? If you go back to the definition of those services, what is counted towards those codes is actually the face-to-face time with the patient. Do all injections, regardless of the medication, billed with the injection code 96372 require a drug code NDC, National Drug Code? Yes, you need to actually report the National Drug Code. And are we required to buy and store the medication associated with the billed injection code? It depends on the medication and whether it's covered as a pharmacy benefit or medical benefit. So that can vary. If a person is in residential SUD, then does this mean they cannot receive mental health services from a separate mental health provider and have them reimbursed? That is a change here. Yes, when an individual is in SUD residential, the staffing should be able to accommodate both conditions that the individual has. Question regarding IHBT prior authorization. Given that some IHBT episodes last several weeks or months, please provide the rationale for PA approval every 3 days. It's not a PA approval every 3 days. It's expediting the PA, and Mary will talk.
It's the 72-hour, I think, is what you're referring to. That's 72 hours of service. So it's not 72 hours totaling 3 days. It means you can be prior auth for 72 hours of service.
So you kind of have to piece those together. The expediting of the PA, which lines up with the 3 days, and Cicely mentioned the total number of hours. So, yep. So I understand that the software company responsible for the prior authorization program will not be ready by July 1. They actually will be ready by July 1, and that's part of why we're doing the webinar, to make sure that everybody understands we are still implementing July 1. There will be more in the PA webinar tomorrow, so please sign up for that. Skip that one for now.
Mental health outpatient 90791 prior authorization. Does this apply to children? Yes. So 90791 is psychiatric diagnostic assessment, and the policy applies to adults and children. It's prior authorization after you have reached a threshold of one encounter of 90791 and one encounter of 90792. At that point, you would need to seek prior authorization.
What is the doc? Okay. So, and then you ask about interactive complexity. So you cannot just apply interactive complexity to every appointment you have with someone. It has to be something that impacts the actual visit that day. So you can't just pick a patient and decide that they're likely interactively complex and then bill it every time. On 90875 has in the workbook and in the manual all of the codes that it can be added to, so you can look there. And then 99354, the prolonged services, also have all the codes that it can be added to in the manual and in the workbook. Okay, so this is asking again about psychiatric diagnostic evaluation, and if you get one per billing agency, which means yes, you would get one for an 84 and one for a 95. However, a psychiatric diagnostic evaluation is not intended just to get the brief diagnosis that you need. When you are doing, and understood that you can ask prior authorization or a different agency can provide one, but it really is supposed to capture the entirety of that patient. So if you are a mental health provider and you are providing a psychiatric diagnostic evaluation, and you should be able to be asking about any SUD issues that they do have as well. So I wouldn't just send them straight over to your 95 to get another PDE if you can assess what they have on the first one. So limitations by client, by year, by provider. Does this mean individual service provider as an agency as a whole? No, this means an agency as a whole. So things like psychiatric diagnostic evaluation is one per billing provider, and the individual practitioners are not billing providers. Service benefits, will they be tracked in MITs? And is it approval based on first billed / adjudicated by ODM or dates of service? So we will track the benefits in MITs, and it is tracked by first in. So whichever is paid first is going to go towards the limit. How does Medicaid count E&M and other CPT codes towards level of care when these services are not timed but event-based? That information is in the workbook, how we calculate that. Okay, so this person says, I'm currently billing 6 units of H004 with the HQ modifier for mental health services, not SUD. Aside from 90853 for group, what is allowed? Okay, so on the mental health side, for group services, you have 90853, which is group psychotherapy. You have your mental health day treatment, hourly and per diem. You have TBS group, you have CPST group, and you have RN services group. So there are many options. Is there a different reimbursement amount when crisis UT modifier are used? No, there is not. It's the same. For SUD IOP, if you meet the minimum 6 hours for children, can you bill for an additional services provided outside of the per diem, or do all hours 6 to 19.9 hours count in the per diem? The per diem is only group services, so everything else is billed outside. Can a CDCA provide TBS and PSR since they are only considered an assistant trainee and not a licensed professional? No, because they are a SUD provider, and TBS and PSR are mental health services. Okay, so this is asking about billing Medicare if the person, I'm assuming you mean an LPC, but the rendering supervisor is an LISW. So 2 things. You would never report the supervisor in the supervisor field for a service provided by an LPC because they do not have direct supervision as an option. Second, you would never put the supervisor MPI in the rendering field. And then 3, an LPC is one of the providers that can be billed directly to Medicaid because Medicare does not pay for them. So, and for the Medicare thing, it's in the slides, and we went over this earlier. So if the service is not covered by Medicare, you can bill it directly to Medicaid. We have a list on the website of services that must be billed to Medicare if they are provided by a Medicare eligible practitioner. Once again, we for Medicare, Medicaid purposes, we have all that information in the slides and on the manual and on the website.
All right, could you please clarify MCR Medicaid billing? If you do, whoops, I'm sorry, that's not the one I was reading. Please explain the approach Ohio MHAS is taking to certification for the Redesign services. We can't answer that directly. Our licensure and certification folks are working on that and are planning to release communication here shortly. The intent is to make sure that everybody gets across July 1st, so hopefully we will have something shared shortly on that.
Okay, is the third-party liability specific to the redesign that goes into effect 7/1, or is that true today for commercial denials that we can bill to Medicaid with the denial code? Where does the denial code need to go on the bill? So I believe today you're probably getting denials for third-party commercial liability. It depends. Yes, if you do get a denial from a commercial payer, they'll give you a denial code, and it's a service that is reimbursable by Medicaid, you can bill it to Medicaid. I don't know where the denial code goes on the bill. That's something that someone more IT-minded would have to help you with, but I'm sure your billing people know where it is. Has there been an addition of an LSW as a rendering provider under the billing Medicaid claims? No, they use a modifier. We've already talked about TPL. Once again, if it's a service that has to be billed to Medicare, that is listed on the website, you must bill it to a commercial, and they will give you a denial code, and then you put the denial code on the claim. If for some reason they will not even allow you to submit the claim, which will not happen for these types of codes. So things like CPT, right now you don't have any of those codes. That's probably why they're not even letting you bill them. But things like CPT will go through. If they don't pay for the practitioner, they will deny it. If for some reason they will not give you a denial code, you need to get documentation for them saying that they don't bill for that practitioner, or they don't bill for that provider. Okay. I think then it is now a little after 12. We need to take a lunch break. We can address some of the rest of the questions later. If we don't get them all, we will respond to you after the training. How long are we going to?
We will take a break for an hour. We will start back up promptly at 1 o'clock. So we'll put something up on the slideshow so that everybody will know we're on lunch break. So we will be back with you shortly. Thank you.
All right. Hope everybody is back from lunch. We're going to go ahead and get started so we can make sure we get through everything and then spend some time afterwards answering some questions. So I'm going to talk to you for a second about the National Correct Coding Initiative, NCCI. We've mentioned it a few times already today, and most of you are familiar with it, but just in case you are not. The National Correct Coding Initiative was required by the Affordable Care Act. It attempts to assure that practitioners are working within scope and control and proper coding. It's implemented, governed, and regulated by CMS, the Centers for Medicare and Medicaid. And providers should check NCCI quarterly updates and adjust your billing accordingly. There was one updated April 1st, which is the most recent one as of now, but they are updated every quarter. They will post the full list of edits in an Excel sheet, but then they also post a change document every quarter so you can see what has changed so you don't have to hunt for any updates. We implemented NCCI October 1st of 2010 for the rest of Ohio Medicaid program, but held behavioral health out. And now with the July 1 implementation of behavioral health redesign, we'll be implementing NCCI. So NCCI policies are applied as claim edits or denials. So there's two types. procedure-to-procedure edits, which are pairs of codes that may not be reported together when delivered by the same practitioner to the same recipient on the same day. And then there's medically unlikely edits, which define the maximum number of units that can be billed by the same practitioner, same recipient, same day. So, PTP, procedure-to-procedure edits. There is a link there. That's where you're going to find all of these NCCI edits. Make sure that you click on the Medicaid edits, not the Medicare edits. So when you download this PTP edits form, there's either going to be a correct coding modifier indicator of 0 or 1. 0 means the codes can never be reported together by the same practitioner to the same patient on the same day. If they are reported on the same day, the column 1 will be the code that will pay, and the column 2 code will deny. So for PTP edits, I have a correct coding modifier indicator of 1. They can only be reported together in circumstances where they are completely separate and distinct, and they are an NCCI modifier is put on the claim to override that NCCI edit. If these services are genuinely separate and distinct, you can override with a modifier, but you need to document that in the medical record. These, as I said, are governed and regulated by CMS, so it's going to be CMS that monitors the use of those modifiers. So an example of a PTP edit is the same physician performs a psychotherapy service and an E&M service to the same patient on the same day. NCCI is not going to allow the psychotherapy code 90834 to be billed with an E&M office visit code 99212 because there are separate add-on codes that for psychotherapy that should have been added to that E&M code. This is one of those ones that cannot be overridden with a modifier. Medically unlikely edits, MUEs, once again define that maximum number of units that can be performed. These cannot be overridden with a modifier. They're always set in stone. An example of this is the same licensed independent social worker, an LISW, performs 2 diagnostic evaluations, 2 units of 90791 with the same client on the same day. NCCI will deny the second evaluation as it is medically unlikely that one client would need 2 complete diagnostic evaluations on the same day. And the reason why these are not overridable is that these have been determined by CMS and the AMA to be medically unlikely. Who's next?
Oh, me.
And now Mary Haller.
Sorry, I was trying to do too many things at the same time. All right. So there's one slide here on peer recovery support. This is a pictorial representation of how peer recovery support is included in the benefit package. You can see that it is covered on the mental health side as a part of the Specialized Recovery Services Program when it is authorized in the client's person-centered care plan. And then also it is covered for assertive community treatment because a peer recovery supporter can be a full member of the ACT team. And that's one of the billable events that can be billed for assertive community treatment. We'll cover that in just a couple of minutes. And then on the SUD side, peer recovery support can be covered as part of the SUD outpatient or SUD residential benefit, and peer recovery supporter can be part of the clinical team. And you can see that service represented both in the manual and in our workbook. All right, assertive community treatment. So we have, I believe, about 20 agencies who have been working with Case Western Reserve to either have their fidelity reviews occur, or they are in the queue to have a fidelity review occur. So if your agency is one of those, thank you very much. If you are not, and you're interested in assertive community treatment, we encourage you to get in touch with Case Western Reserve and get on the calendar to have a fidelity review done. There's also a lot of technical assistance information up on the website about assertive community treatment, and we've got some more information about that in the coming slides. So here is the timeline for assertive community treatment. You can see that the service will begin on July 1st with the rest of the benefit package. This slide says June 1st is when agencies may begin submitting PA. We're working with our new vendor on that. It's going to be the beginning of June. I'm not sure that June 1 is going to be the exact date, but we will send out a notice via MITSBITS and via the BH newsletter that Mental Health and Addiction Services sends out to let you know when prior authorizations for assertive community treatment and IHBT can begin to be submitted. If you are treating an adult who is enrolled in MyCare, you will want to be working with your MyCare plan on assertive community treatment, and you will need to be submitting your prior authorization requests to the MyCare plan. They will be performing that function. This slide just tells you why we have decided to pay for assertive community treatment. We're investing in what works because this is an evidence-based practice that's supported by many years of research. Our goal is, throughout the Medicaid program, is to improve health outcomes. With assertive community treatment in particular, we expect a reduced use of emergency room and inpatient hospital admissions, increased stability in community living. ACT is focused on those Medicaid enrollees who have very complex mental health conditions and who meet the other eligibility criteria that is outlined in our 5160-27-04 rule in our Medicaid rule package. And only ACT teams who meet fidelity to the model are able to render and bill for the service. Here is the resource from SAMHSA regarding fidelity measure. We are going to be using the DACTS model, the Dartmouth model, which is the older model of fidelity for starters. It is our hope that we will move towards the more modern TMACT fidelity measure in the future. We're hoping to make that transition as part of the carve-in to Medicaid managed care. And that is the first bullet on this slide. As I have said earlier, ACT enrollment is fully prior authorized by our PA vendor. The caseload can include both Medicaid and non-Medicaid enrollees. There's no problem with having a mixture of Medicaid and non-Medicaid enrollees on your caseload. Of course, Medicaid will only be paying for the Medicaid enrolled individuals. Teams must assure that their caseload doesn't exceed their FTE capacity, and it's fine for agencies to have more than one ACT team. That's not a problem. We have some requirements for ACT team leaders. They must be dedicated only to a single team. They must be a licensed clinician. Our preference is for an independently licensed clinician with supervisory endorsement, but we do know that there are a number of individuals who are dependently licensed who are serving in team leader roles, and if that's the case, just get in touch with us and we will figure out a way to link that dependently licensed individual with your team. And the team must be employed by an agency that's enrolled in MITS as an active Medicaid provider. There is no Medicaid payment for supported employment or vocational rehab services as a part of assertive community treatment. We recognize that's part of the model, but that is not allowed for Medicaid to pay for unless it is being provided to someone who is in a Medicaid waiver. And team members are responsible for providing the ASAM Level 1 services to enrollees who have a dual diagnosis as a part of their ACT billable service. Here are the rates that Medicaid will be paying for the interactions of different members of the team with your caseload, with your clients who are enrolled on your ACT caseload. We've covered this a lot. I will cover it in general terms today, and if you want more specifics, we can talk about that if you want to ask questions. So these are the rates when a physician is serving in the role of the prescriber on the team. These are the rates when the prescriber on the team is an APRN, Advanced Practice Registered Nurse, or a physician assistant. Other than that, the rates are identical on these two slides. So you can see the rate is higher for the MD-DO than it is for the APRN physician assistant. So basically these are categories of activity. I have started to call them billing units or billing opportunities. So what I'd like to do is just run through the patient scenario here and then talk to you about how your team might use these various members of the team to perform billable activities that are performed for the members of the team. So here's the patient scenario. This is a 57-year-old client who's receiving services from an ACT team. She has schizophrenia and a long history of multiple inpatient hospitalizations. She continues to have poor medication compliance and has recently started taking clozapine, so she requires regular nursing visits to monitor her clozapine. So she receives multiple services throughout the month from the team to help her maintain her independent living. So if you look at the next slide, which is the calendar of the activities of the ACT team with this patient, you can see here that she has a monthly visit with her psychiatrist, and that occurs, as you can see on this slide, on the 16th of the month. That is a face-to-face visit, and it must be 15 minutes in length in order to bill for that billable unit. Weekly, she has an RN visit her to do medical monitoring and draw blood. The RN provides education regarding her medication and the need to take it daily. So you can see the RN visits occur every Monday. Every evening and twice a day on weekends, an unlicensed BA staff member goes to Mary's home to prompt and monitor her with her self-administration of medication. You can see the BA visits there. That's the light blue line that goes across every single day of the month. Weekly, an LPN provides verbal direction and supervision when Mary fills her medication box. You can see the LPN visits that occur on Thursdays. And weekly, a peer recovery supporter visits Mary, and you can see that those visits occur on Sunday. Now, which of these visits are billable? The ones that are dark blue or the ones that are billable? And you can pick any ones you want. We picked the ones that were closest to the beginning of the month because we thought that made sense financially. You would also notice that we did not bill for the RN visit because if you look back at this billing chart, you can see that the master's, RN, and LPN group are all the same rate. So any member of the team who has a master's degree or who is an RN or an LPN would bill that rate, the $251.91. Then any member who has a bachelor's degree would bill the $199.70, and the peer recovery supporter $159.24. You can see on our calendar here, we chose not to bill the peer recovery supporter. Instead, we billed the unlicensed BA because that rate is higher than rate for the peer recovery supporter. That was just a business decision that we made in this example. So you can see, as is the case with the ACT fidelity model, the team takes turns visiting the individual, providing services that are on their treatment plan. They're in contact with the person throughout the month, but these 4 visits in the dark blue and the navy blue are the visits that are billable events using this billing rate that is described on these 2 charts here. So I hope that wasn't too terribly confusing. If you have additional questions, please feel free to ask them, and we'll try and get to them when we get to the end of the presentation. We are assuming that ACT is not a service that's covered either by Medicare or commercial insurers, so you don't need to worry about submitting any claims to Medicare or to a commercial payer. You can submit them any claims for one of your 4 billable events throughout the month directly to Medicaid without submitting to Medicare or without obtaining a denial code for that claim. As I said earlier, the teams will need to have a fidelity review and will have to have a passing score on that fidelity review. We have contracted with Case Western Reserve with their Center for Evidence-Based Practice to perform those fidelity reviews for us. The team has to achieve a minimum average score of 3 on the DACT's fidelity scale. And once that has happened, then we will be enrolling your agency's team in MITS, and then beginning July 1, you will be able to render and bill for ACT services using the methodology that we just described a few minutes ago. Teams who don't achieve a minimum fidelity score are not penalized. They can seek technical assistance from Case Western. There is an availability for technical assistance with Case Western through an agreement that they have with the Ohio Department of Mental Health and Addiction Services. They do regular training events and webinars. They also have a lot of useful educational information up on their website about assertive community treatment. As we said earlier, ACT is a fully prior authorized service. So we will be reviewing the person's eligibility. You'll have to look at all of the eligibility criterion as it is outlined in our administrative code rule. I think I said earlier 5160-2704 is the rule in our Medicaid rule package that covers assertive community treatment. Prior authorization will have to be submitted using the MITS PA subsystem. And we're doing a webinar tomorrow where we'll be going over very specific instructions about how to get into MITS and how to submit a prior authorization and upload the medical documentation. And that is the link to register for that webinar if you have not registered already. Here is a few bullet points summarizing the eligibility criteria. The one thing I would point out to you is that we did have a policy change recently where we allow, as a substitute for the adult needs and strengths assessment, the submission of SSI or SSDI determination. We are working out a way for our PA vendor to enter into our Ohio benefits system and confirm the SSI or SSDI eligibility for clients. So if your team does not have the documentation handy, you can simply note SSI or SSDI eligibility on your PA submission and then have that confirmed by the PA entity. You can always submit an ANSA, however, because if there is some question about the person's eligibility, that might be the quickest way to get them approved for assertive community treatment. ACT is a lock-in benefit, meaning that when someone is enrolled on an ACT team, no other Medicaid services will be paid except for behavioral health medications, recovery management through the SRS program, and SUD services that are prior authorized. ACT enrollees can receive other non-behavioral health Medicaid services like inpatient and emergency room visits, physician visits, and specialties, and prescriptions. So basically, if the person is enrolled in an ACT team, we expect that the ACT team is fully responsible for their mental health and for at least the ASAM Level 1 SUD treatment services for that individual as a part of the ACT team payment that's being made. If one of your members is hospitalized, we expect that ACT teams maintain contact with those enrollees during their hospitalization and that they are a part of the admission and discharge planning. However, these are not billable events. When someone is in a hospital, the hospital is being paid for their comprehensive medical care. We do expect that ACT teams will coordinate with the hospital, and then when the person is discharged, then the ACT team will begin performing billable activities again with that individual. And depending on the length of stay, if it's a long hospitalization, the ACT team may consider whether they want to maintain the individual on their caseload for billing purposes or discharge them. It's a business decision that we would leave up to the teams. We do expect you, though, to maintain contact with the person from a clinical perspective. Disenrollment from ACT, we expect that this is something that is done carefully. If it is a planned disenrollment, that there is a transition plan that is done in partnership with the consumer and with their significant others. We do recognize that disenrollment does occur without notice, that ACT enrollees may lose touch with the team for some period of time. So we are recommending that the ACT team might want to disenroll the consumer after a month of no communication, simply because this is a lock-in benefit, and until that person is disenrolled from your ACT team, they will not be able to get Medicaid paid treatment services from another community behavioral health agency in Ohio. And then the ACT team, of course, can re-enroll that individual if they do regain contact with them. This is your checklist. If your agency is developing an ACT team or wants to develop an ACT team, just a reminder that your independently licensed members of the team need to be enrolled in Ohio Medicaid and affiliated with your agency. You will want to contact Case Western Reserve to schedule a fidelity review. You would want to have a member of your team who is competent in conducting the adult needs and strengths assessment, and also be able to verify SSI or SSDI status. If you can't verify, you just should be able to note that. You should have reason enough to note that on the PA submission for the individual. Your agency needs to have an IT system that can support the medical documentation and the billing nuances that we described earlier. And you will want to attend the training tomorrow on MIT's PA functionality and be prepared to submit PA requests. You can go about the business of collecting that information and collecting your medical documentation so that as soon as the system is open for PA submissions, you can begin submitting them. And MITS is open 24/7, so there's no time constraint on when a PA request can be submitted. Okay, we'll move on to intensive home-based treatment. This is the service for youth who are at risk of being removed from their homes. Again, this is a team-based service. The teams are generally smaller. Teams will need to meet or exceed a fidelity score that is set in our rule. And we also have a link to it on a couple of slides from now. The employing agency has to be certified by Ohio Mental Health and Addiction Services for the IHBT service. And the team members must be licensed by one of those boards: psychology, counselor, social worker, and marriage and family therapy. Again, IHBT is fully prior authorized from day one, and the maximum number of hours that can be authorized in the prior authorization is 72 hours within a 6-month date span. So if after 72 hours the youth needs more service, then the agency will just simply need to submit an additional request for prior authorization. I hope that makes that a little bit more clear. We had a question on that earlier about 72 hours, thinking that it was 3 days, and it's not. The 72 hours was calculated based on the average number of hours per week that is expected to be provided as part of the fidelity review. This is the eligibility criteria for children, youth who are receiving intensive home-based treatment. This is detailed in our Ohio Administrative Code Rule 5160-27-05. 05 is the IHBT rule, and you can find that at the Register of Ohio. This is the link. I think that's a hot link to the fidelity document. You can also find this on our bh.medicaid.ohio.gov website. It is a 6 or 7 page document that goes through each of the fidelity requirements for an IHBT team. And if you are interested in IHBT, and you haven't yet contacted Case Western Reserve, please do so. It is the Case Western Reserve Center for Innovative Practices, and we have the contact information on our bh.medicaid.ohio.gov website. If you have any questions, just let us know. We can get you in touch with them if you need to be in touch with them and haven't been already. This is the code and the rate for intensive home-based treatment. It's fairly simple. One code, one rate. The rate is for a 15-minute unit. All of the billable services must occur face-to-face in person. It is expected that services will also be delivered via telephone. They could indeed be delivered by video conference, but the Medicaid billable services are those that are face-to-face and in person. And that is the end of my section. Do we need to pause for questions, or?
It's up to you if you'd like.
It's up to you before I leave.
I haven't been watching them because I've been presenting, so.
Okay. I don't know where we're at.
I don't know where we're at.
Okay. Interactive complexity code. For mental health outpatient, 90791, prior authorizations is also applied to children. So yes, we answered that one. You do need to seek prior authorization even for children. I think I'm not sure I see the typo. I think I answered it previously that you cannot apply interactive complexity to every appointment. You just need to document why that service was interactively complex. The American Academy of Child and Adolescent Psychiatry has some pages on interactive complexity. It's actually posted to bh.medicaid.ohio.gov. That might help you with some of your questions about interactive complexity.
We did that one already.
So someone is asking if there is a break in the time that the patient is in an IOP group and the time they attend. Will they still be able to bill IOP for the day? How do you document the start and end time? Well, you need to document that they were there for the minimum amount of time required to bill IOP. We're not saying that someone can't use the bathroom, but you can't count like them in an individual service or them getting lunch or something like that as part of your IOP group time. They need to be receiving group services for the minimum amount of time. No, TBS is not billable for phone calls. So TBS cannot be billed for a phone call with a client or a significant other, only face-to-face. And what I said earlier was that if the service is allowed to be billable by phone, it will say explicitly that it can. Place of service 53 states you had to be certified by Medicare as a CMHC. If not, you use place of service 11. That's not a Medicaid rule, but if you feel more comfortable using place of service 11, that's fine. I have a provider who is an LPCC and sees patients in the office. She currently only bills 90787 and 90791. Does she need to change anything? Yes. 90797 is not a billable code anymore, and 90791 is, but it has a limit of 1 per year per patient per agency. You need to go to the code chart, look at the LPCC tab, and see all the codes they can bill. It'll be profitable for you as a business to understand that they can now bill all the psychotherapy codes, psych testing, day treatment, extensive amount of other services. So I would not just limit them to 90791. The hospital Medicaid email is hospital_policy@medicaid.ohio.gov. Is there a place, website, or number we can call to see if we are registered with Medicaid and affiliated with our agency? Can we check to see that they are complete for our agency? Whoever has access to your MITS portal needs to do it from there. You log on to your MITS portal and you look at your group members, and it says every provider that is enrolled and affiliated with your agency. If you have questions about certification with mental health and addiction services, you can contact them, their office. Yeah, it's on the website. ODM still refers to QMHS and CMS, but I was under the impression that OMHAS now has combined those individuals under one category called QBHS. So QBHS under the new proposed rule from OMHS could collect urine. Correct. Incorrect for Medicaid purposes. We still have them as separate provider agencies, 84s and 95. They're completely separate. So the practitioners are separate too. So for Medicaid billing purposes, it's a QMHS for mental health, and then there are CM specialists on the SUD side. Remember that the Ohio Mental Health and Addiction Services rules are agnostic to payer, so they are applicable to many different payers in Ohio, whereas for Medicaid reimbursement, you have to follow our rules. Can a facility licensed by the state for SUD-only services provide co-occurring treatment services? For Medicaid reimbursement, if you are enrolled as a provider type 95 SUD provider, you can only provide the SUD services. If you're enrolled as a provider type 84, you can only provide the mental health services. If you are both, you can provide both, but you need to bill them under their separate provider types. Can a diagnostic assessment and therapy be billed on the same day, back to back? You need to look at the NCCI edits on that. Can you clarify your IOP example of a patient who is sick on the third day? IOP group code can only be billed if the patient actually receives more than 9 hours of service within the week. Correct. No, as we were saying, a person who's in the IOP level of care is in that level of care because they meet the requirements for that level of care, which means that they need more than 9 hours of services a week. However, if they miss a day, that doesn't mean that they are less in need of that level of care. So they could still be in the IOP level of care. You just don't bill the group service if they did not come to group that day. How easy is it to change from a provider type 95 to both 95 and 84? You need to go through certification with mental health and addiction services for mental health agency, and that's how you get enrolled with Ohio Medicaid as a provider type 84. And they'll be issuing more information on mental health certification, so I'm going to skip those questions. As Doug said, you'll be getting more information on it. So we keep hearing that we may bill a 99215 instead of a 90792 for a psych eval or first visit with a prescriber. Is this correct? You need to bill the code that is the most appropriate with that service. A 99215 is the highest level of evaluation and management service for a established patient. So you couldn't use that code for a first time meeting with the prescriber anyway, but you need to understand the difference between a psychiatric diagnostic evaluation and a evaluation and management visit with a physician. So we're getting a lot of questions on what can be billed together on the same day. I'm going to skip those, and I'm actually going to refer you to our website, bh.medicaid.ohio.gov. On the manuals tab, there is a document under IT resources that lists all of the codes and what can be billed on the same day and how they interact. So if you have a question on what two services can be billed on the same day and reimbursed, you need to look at that chart. So for anyone who can't hear us, we do have a lot of people who can hear us. It may be that you have muted us on our end, on your end, but we are telling the audio, and I just realized that even if you can't hear us, you wouldn't have heard that announcement anyway, so probably not useful. I just want to assure everyone that we are projecting and recording. So if a patient comes into the office for withdrawal management, ambulatory detox, what is the code for physician-based services? The RN and LPN code H0014 is for their services. Other individual services would be billed outside of that as permitted. On slide page 47, example of 120 minutes of crisis psychotherapy reported. Do you use 90839 for 60 minutes, use 90840, and again 90840 for the additional 30 minutes, again when reporting via electronic paper? So I think you're asking about how you bill, and yes, the example is laid out how you should bill it. 90839 for the additional 60 minutes, and then 90840 is for each additional 30 minutes. So if you've gone 120 minutes, you would add 90840 twice. Can the trainee provide psychotherapy in the client's home while the supervisor is in the office, and it can be considered direct supervision? No, that's general supervision. If you read the definition of both, general is available by phone, direct is immediately available and interruptible. So if someone is in the home and the physician or the supervisor is in the office, that's considered general supervision, and you would need to bill it that way. Can a BSN provide direct supervision for clinicians with degrees below them? We don't, no, RNs cannot provide supervision and be the supervisor on the claim because there are no people that they can supervise that require that supervision on the claim. Can LPCC supervise social worker trainees, LSWs, LPCCs? We refer back to the licensing boards on that. Direct supervision. Supervisor can be interrupted and immediately available. Can that be available by phone or only on site? Only on site. As we said, available by phone is general supervision. Can you clarify that 50% of the session does not require the LISW to be present in order to bill under their MPI? I'm sorry, I don't understand that question. You would only bill under someone's MPI if they provided the service. If you're referring to supervision, they don't need to be there at all, but they need to be directly available and immediately available and interruptible if you're going to bill them as the supervisor. In regards to supervision for a case, can some claims be submitted under general supervision while others are submitted under direct? Yes, that's the idea. You would need to submit them on different claims, but yes, if someone is under direct supervision one day, But under general, the next day, they would need to be billed differently because they're going to get different payment rates, and it needs to match the actual activity that occurred. For duly licensed providers, a provider is an LISW and an LICDC. If they're enrolled as an LISW, do they also have to enroll under the LICDC role? Ohio Medicaid cannot have people enrolled as multiple different providers. We are working on different policies in regards to when managed care carves in, and if that is something that can be accompanied there, but we can only accept one NPI per provider type. So in the case of an LISW and an LICDC, you need to pick the one with the largest scope. You're going to want to pick the LISW because they have the ability to do mental health and SUD services. The supervisor MPI that needs to report it in the supervisor field is actually the one who provided the direct supervision for that service on that day. For add-on codes like the 90840, you still need to use the practitioner modifier for that code as well, correct? Yes, every code that you bill needs to have a practitioner affiliated, whether via rendering MPI or with a modifier. Would you please define a master's level or bachelor's level trainee? Well, it's just someone with a master's or a bachelor's. I guess I'm not quite sure what the question is. If you look at the workbook, it talks about all the different practitioners that can build codes. Okay. We have a new LICDC starting in mid-June from out of state. Her license was just approved, but it'll be enough time to get her registered. You will need to submit it as soon as you can. If it's not ready by July 1, that does not mean that you are going to lose those claims. Medicaid backdates back to the date of license. So if your LICDC, you submitted their enrollment now and their enrollment became active as of July 15th, everything that they did between July 1st and July 15th is billable. You'll just need to submit the claims after their enrollment is processed. The minimum daily requirement to bill the SUD residential per diem rate. There is no minimum daily requirement. The assumption is that they will be there. They need to meet the level of care and that they will be there all day because they are staying there and that you are providing all the services that that person needs in that day. An RN or LPN can only bill for services that have an order by a physician. So that's just a requirement for all billing for RN and LPN. Just to clarify, an LSW billing psychotherapy under general supervision will not have to list the supervisor LISW as the rendering or supervisor on the claim. That is correct. Under general supervision, you will just list the modifier and the billing MPI. You do not need to put anything else. If you're looking for the provider affiliation list, just go to our website, bh.medicaid.ohio.gov/manuals. It's on that page. When you are billing a large counseling group, does the second staff person have to have the credentials to bill? Yes. So if you are providing a group and you have one LICDC and one CDCA, that's completely fine. They can both provide that service and bill, but you couldn't bill it with someone who is not eligible to provide that service. If I, as an LICDC, participate in a group of 24 clients and my co-facilitator is a CDCA, what rate do we bill at? You bill at the highest level credential. Is there a specific billing code for a nurse conducting a health history exam under SUD? All of the services that a nurse can provide are on that tab with the nursing codes. So they will likely bill it under T1002, which is their RN code. Can an RN or LPN see client first and diagnose before seeing a doctor for an outpatient setting? An RN or LPN do not have the scope to diagnose. If a counselor or CPST go to the jail to provide an outpatient service, can Medicaid be billed for this service? No, Medicaid does not pay for services in jails. For 90791 and 90792, the limit is one of each code per person, per billing provider, per calendar year. Can a licensed provider who typically provides therapy provide CPST groups? A licensed provider can provide CPST, and I would just encourage you to go to the code chart and click on the tab to see what they can all provide. Who can tell us where the denial code needs to go on the bill? You can contact our Medicaid ombudsman, and they can help you with that. Just call the provider hotline. Dependently licensed and trainees generally are not paid by commercial insurance. Do we still need to bill the insurance? If it's one of the codes that has to be billed to commercial, which is one of the codes that has to be billed to Medicare, yes, you do. And then you would get a denial code, and you would bill it to Medicaid. With a lower licensure clinician, should the MPI on the claim be the agency's MPI if not billed under a supervisor? If it's provided by an unlicensed staff member under general supervision, you leave the rendering blank. You put the billing MPI in the billing field, and you put the U modifier to represent the unlicensed clinician. If it's performed under the direct supervision of a supervisor, you still leave the rendering field blank. You put the supervisor's MPI in the supervisor field. To bill for ACT, do we have to be a part of an agency, or can this service be provided out of a provider practice? It's only for community behavioral health providers, 84 and 95. H0048 is not listed in the provider manual for peer recovery supporters, but it has a rate in the workbook. We'll check on that. So I did want to talk about this one. It says we clarify whether for a group counseling session, we might have 26 people in the session, 3 counselors, and we can bill all 26 individuals under the one counselor with the highest licensing. That is correct. However, an example you said, if we have a doctor level leading or in the room, all the claims could be coded with this provider MPI. If the doctor level is leading, that is correct, but simply being in the room does not allow you to bill under their MPI. They need to be the leading the group or co-facilitating the group. They have to have provided the service. Could you be more specific about when to use place of service 99? In the manual, it says which codes can be used under place of service 99, which we've defined as community. The link in the presentation to the NCCI edit takes me to page not found. If you Google NCCI edits Medicaid, it should come up, and we'll check that link. Is there a minimum number of contacts a month for ACT clients? There is not a minimum, but we do expect that you are handling all of the needs of the client for that month. Are CNPs included with the APRN group? Yes. For young adults, does a young adult need to first receive services from an IHBT team before they can be accepted and approved through an ACT team? They won't overlap. IHBT is for youth and adolescents, and ACT is for adults. What codes are used for case management? Well, there are multiple codes that have some case management aspects on the mental health side, TBS, PSR, CPST, and then there's a code called case management on the SUD side. So agencies can be paid for crisis, even if they're not, if someone is enrolled in an ACT team, but that is the only service that other agencies can be billed for, can be paid for while someone is enrolled in ACT. So this person's asking about disenrollment from ACT. The agency that is the ACT team or the patient has to do the disenrollment, and they have to ask the agency that they're enrolled with to do the disenrollment. A third party, another agency cannot disenroll someone from ACT. So it's your responsibility if someone shows up and they're on an ACT team, you can find that out in MITS, and you should be contacting their ACT team to get them reaffiliated. Have you covered peer support services yet? Yep. Please look at the manual and the code chart. It's all there. And we're about to talk about, and we already talked about peer, right? Okay. You can find out if someone's in a lock-in when you look in MITS or when you're checking their eligibility. You need to look for documentation requirements, including supervisor in 5160-805. Ohio MHAS is aligning their rules with the ASAM levels, so that's what you'll need to follow. Everything that interactive complexity can be billed with is included in the definition on the code chart. At this time, we're not anticipating any delay of behavioral health redesign and are moving forward with July 1, and we recommend that everyone is ready to also implement July 1. General supervision is available by phone. Direct supervision has to be in person. If it's not listed in the manual as an allowable place of service, then it's not an allowable place of service. There's open enrollment for providers to become, there's no open enrollment for Medicaid providers. You maybe think, oh, I'm sorry. I don't think there's open enrollment. There's not open enrollment for Medicare providers. You may be thinking about open enrollment for Medicare recipients. They might have something like that, but not for providers. You should just email, if you have questions about outpatient hospital, you should just email that outpatient hospital box. Someone there will get it, and they can have a call with you to talk through all your options. CPST can still be provided via telephone, but the GT modifier, if you look at the definition of it, is not telephone, it's secure video conferencing. So that's what it means in the manual. When you see the GT modifier, it means secure video conferencing. It doesn't mean telephone. How is supervision handled during supervisor vacation? You need to just report the supervisor that's actually providing the supervision. For questions about what an LICDC can bill, please look at the manual and the code chart. What can be billed on the same day is on our website, bh.medicaid.ohio.gov/manuals. You should just be familiar with all of the documents on that page. Can an advanced practice registered nurse provide order for med-som, or does it have to be a physician? An advanced practice nurse can order services for an RN LPN. We don't cover the med-somatic service anymore. all nursing services have to be done under a doctor's order. That's a nursing board requirement. RNs and LPNs cannot operate without an order. If you want to know when you can use the GT modifier for secure video conferencing, look at the manual. This whole type of bill for all of this whole presentation is about a 1500. This has nothing to do with UB. We're talking about community behavioral health agencies, 84s and 95s. LSW can't be the supervisor on a claim because they don't have an MPI. If a practitioner is in a master's program but has not completed it, do they bill as a master's QMHS or as a bachelor's? They need to bill as a bachelor's because they do not have a master's as of yet. IHBT, if you have questions about hospitals, you need to message that hospital box. If you want more documentation on any of the coding matrix, you can go look at the website. All right. You don't need to use a modifier for telephone services. H0016 is not a covered service anymore. If a physician orders a service, that does not mean it's medically necessary. You need to provide medical necessity documentation. Can an LPC with a master's degree bill Medicaid without supervision? They're under direct supervision. And yes, we are recording this presentation. And I'm going to stop answering questions now.
Why don't we continue on with the presentation?
And now back to our regularly scheduled programming, if you will. So thank you, Cicely, for getting us caught up through those questions. A number of them are repeats, so you'll pardon us if we don't address every single question, especially if we've previously addressed it, maybe once or twice. So our next section is on care coordination. So what you see here is a heat map produced by a consultant agency to the Department of Medicaid looking at behavioral health spend claims and medical spend claims. And what you see is we actually have 3 areas marked. You know, the top right, bottom right, and top left, for want of a better term. And these are areas where patients can be identified that would likely benefit from some level of care coordination. Currently, we have care coordination embedded in some of the community-based services. We have care coordination embedded in the managed care plans. And Medicaid is bringing online the CPC Comprehensive Primary Care program. I think at last count there were like 96 practices enrolled, which also carries a level of care coordination. So, but going through the work of understanding how care coordination intersects, that's why we mark these 3 areas. Folks with high medical spend, high behavioral health spend, that's the top right, are likely to benefit from care coordination, probably managed mainly through the Community Behavioral Health Center. The bottom right are those individuals with high medical spend but low behavioral health spend. Those individuals are probably best managed at that point through the comprehensive primary care or through the medical. Then you have our individuals who have low medical spend but high behavioral health. Again, that's probably an area where it's best to have the behavioral health doing that work since the bulk of the services are in behavioral health. I also point that one out because sometimes when you look at these, you may try to distinguish adult versus kids. You know, adults are probably more likely in the medical spend and behavioral health, the 2 on the right. Kids potentially could show up more in this left one because of the low medical, high behavioral. So we've kind of got a pretty good heat map here showing the patients that would likely benefit from care coordination. That being said, here is the picture or vision, if you will, of accountability for care coordination as we move forward. I mentioned managed care. We have talked about what we call our qualified behavioral health centers. Back in April of 2015, a little more than 2 years ago now, we took an opportunity through the core team to go through looking at, issues or models related to care coordination. We had models 1, 2, and 3. I won't rehash that for anybody, but if you're really interested, I still have all the documents and can send them to you. The system landed on model 2 commitment, and the state agreed to move forward with that between Medicaid and MHAS and the Office of Health Transformation. What that model had in it was care coordination managed by qualified behavioral health centers. That's why you see that down there in the bottom left. And then under the comprehensive primary care, the CPC program, care coordination is managed through the primary care entities. More can be found on Medicaid's website if you're interested in looking at that. That's the medical home model that Medicaid is bringing up as we're talking. Again, Medicaid managed care has some embedded in it, but the concept here is actually to get care coordination as close to the patient as you can. And we also envisioned that the Qualified Behavioral Health Center and the CPCs would be working and having mutual accountability, especially when there's some financial incentives to have that level of an arrangement there. So there's a lot of work underway here. We will be sharing it back with our work group, so you'll see additional information as we move forward in the care coordination arena. Rule updates real quick. We've talked about it. Cicely can rattle off pretty much all of them from rote memory at this point on the Medicaid side. But we mentioned that there's also the MHAS rules that are going through restructuring and implementation for April. So we've actually done this in a number of stages. Back in February, both departments worked on rule changes, and we went through an informal procedure, if you will, and that was shared with our benefit and service development work group. Commentary was received and changes were made. That's part of a public process. Then there was the Common Sense Initiative public comment period that was open from March 17 through March 31. Additional feedback was gained through that, and updates have been made and rules republished to meet our July 1 filing date. Rules are actually submitted and filed. That was on the 14th. Updates again were shared with the Benefit and Service Development Work Group all along. I believe on the Medicaid side there was something in excess of over 300 comments, if you will, on the rules at that point in time. So there was a lot of response from the field. Oftentimes there were very similar comments, so those have been updated. I believe even as of this Friday, that's when some of the most recent updates were pushed through on both the mental health and mental health and addiction services and Medicaid rules. Not this coming Friday, but last Friday. Thank you, Mary.
Friday the 19th.
Thank you. So if you need those, that's why we keep saying go to the Register of Ohio, and you can search for those rules either by number or filing agencies, and you can get those rules. There were public hearings May the 15th and May the 17th. JCAR hearing is coming up end of this week. Next week.
The 30th.
Yeah, May the 30th. And then the rules are set to be final filed with being effective July the 1st. So we are reminding folks we are on track to have our regulatory structure in place to make sure we are supporting this come July 1st. So stakeholder resources. Throughout the presentation, we've talked about a lot of change. So in addition to agencies and state going through this, individuals are coming along with the changes too. So we've got some information out there to help with that. So Medicaid enrollees can always call the consumer hotline. That's the 1-800-324-8680 number to speak to a person to seek help or answer to their questions. Medicaid recently brought on their beneficiary ombuds person, which is Sherry Warner here. That's her direct phone number, and that's her email, where individuals can get in touch, and she will help them with whatever inquiries they have. On the MHAS side, we have our client rights and advocacy resource that people can reach out to. They do all the time. In fact, I get calls routed to me from it. So if an individual is struggling and needs some assistance, there's another doorway for them to come and seek help. NAMI also has a helpline, National Alliance on Mental Illness. That's there. The Board Association, the Ohio Association of County Behavioral Health Authorities, actually has their board directory available. People can contact the local boards for assistance too. If an individual needs help regarding managed care, they can come in through the consumer hotline again, and then there's our myriad of specialized recovery services resources, the three, if you will, recovery management entities there, phone numbers and direct emails to get in touch with folks there. So there are many ways. We don't consider there any wrong door, and we all go through what we can to help anybody, especially if they need some assistance with this. Workbook updates. I will not go over all this because, as Cicely mentioned, she's been working to make get a newer one posted out there shortly. She does a yeoman's job keeping this thing up to date, but unfortunately there are a lot of links, and sometimes I believe her term earlier was it does get a little wonky and we have to reissue it to fix something. And we appreciate it. If somebody sees something wrong, let us know. We're not offended. We know that there are times where it's not quite correct or not everything is linked correctly. So if you do see something, feel free to contact somebody, and shortly we'll make sure folks know when there's a new one out there. Quite frankly, this one is just where we bumped up the payment amount for urine drug screening by another $3 to help cover the cost of overhead, if you will, associated with collecting a urine specimen, whether it's tested there on site through the Instacup, if you will, or sent for actual laboratory testing. Place of service, we've mentioned this a few times, that hospital and 99 other or community were not in the recognized list of places of service. We have brought them back. Please pay particular attention to the charts in the provider manual. That is where you will find whether Medicaid will actually pay when the place of service is reported. Those are at the tail end of each of those charts. I won't go through 99, but please pay attention. Here's the definition of 99 being community. Technically, the HIPAA Code 99 is other, but for Ohio, we've given you guidance on community and when that's appropriate to use that. You do need to keep in mind, again, a caution. You cannot use place of service 99 to circumvent, if you will, the incarcerated prohibition. Documentation. Both departments fully support the use of EHRs, including structured drop-down or checklist options that support individualized clinical documentation. Cloning, if you haven't heard that before, it's actually a term. Think about it as cut and paste. You cannot do that. Individualized clinical documentation needs to be exactly that, individualized. And if you want to see a little bit more about it, you can go to this link here from CMS. It's some program integrity information about EHR, use of EHRs, and federal information about that. Okay. We have mentioned bh.medicaid.ohio.gov/manuals. This is actually a shot of that website. Looking at it, I know it's a little out of date, but we show you here exactly where you can go to get to the IT resources we have referenced. There is a Excel file, Services Billable to Medicare, that contains all the codes that can be billed to Medicare and covered by Medicare. And I believe there's a second tab that has all the codes that do not need to be billed to Medicare because they don't cover them. There's a supervisor rendering ordering fields document. It's very nice. It shows by service code groupings, if you will, what needs to be in what field when. I don't know a better way to say that, but there's a services crosswalk. It's a large XY table so that you can find any service across or up and down, and then look at all the other services that it interacts with. There is a legend in there so you can understand what the nomenclature means that's inside the cells. There's another similar one, but it's very specific to ACT and IHBT. I believe Mary mentioned earlier, you have to keep in mind that when these are lock-ins, that other agencies may not be able to get services paid when individuals are either with an ACT or an IHBT team. There are diagnostic code groups. I think it's about 6 or 8 groups, and you can see all the diagnosis codes that are in those groups that are associated with the services there. There's a limits, audits, and edits document that's been used a lot to communicate with the MITS vendor on Ohio custom limit audits and edits. We don't duplicate NCCI edits in there because those are nationally managed, so we don't have to put them in. They're just part of the NCCI engine. Then there's also an EDI IT question and answer. There's an EDI IT work group, if you're not aware, led by Joan Schlagheck, and hopefully I got her name right, and Nicole Small from Medicaid. They meet, is it weekly now? What, bi-weekly? And they document the Q&As there and post that out for folks to see. Right. File testing. We are open for file testing. There are a number of providers who have worked either directly as their own trading partner or through a vendor to test files. I believe it's gone very well from the feedback that we've received from those who have begun testing. Keep in mind, testing is open 24/7, so if somebody really would like to test a file at 3 o'clock tomorrow morning, you're more than welcome to. This is getting everyone lined up for go live. The MyCare plans are working on their timelines for testing, all in preparation for our July 1st go live. So a little bit more on the testing. There is a rapid response team, so there is literally a room over at the Department of Medicaid with phones and computers and large visual aids up on the walls where entities that are testing files can get in touch with a live person to ask questions or help understand how to interpret the responses that they're receiving. I believe we're getting ready to release a MITS Bits update today on this. I would also like to note that we are coming to, this is the Memorial Day weekend, so the rapid response team will only be available through 4 p.m. this Friday. It will not be available Saturday, nor will it be available Sunday or Monday. It will open back up Tuesday morning. So, staff are able to take advantage of the long weekend themselves. It doesn't prevent a vendor from testing. You just won't be able to get in touch with a live person through the rapid response team from 4 o'clock this Friday through Tuesday morning.
They can leave a message. And if folks are testing this weekend, feel free to leave a message. We can monitor those messages remotely, and if you need us to get back with you, we can do that. So if you do want to get work done on testing this weekend, just go ahead and leave a message and we'll get back to you.
As I said, I believe we have another MITS Bit, so if you're registered for all that, more additional information on that. These just are the times where you can call in. It's generally 7:30 to 7, Monday through Friday, and 8 to 1. Okay, for July 1st, this is kind of the last set of guidance here to get you to July 1st. Make sure that your practitioners are enrolled, those that need to enroll, the LISW, physician, etc. If you haven't done that, you may have a little challenge getting to July the 1st, but you still need to go ahead and do that. So enrollments for practitioners, they need an NPI. They need to do the enrollment through MITS. Respond quickly if you get a contact from Medicaid. A lot of times something wasn't actually attached to the application, which can delay it. And then once it's approved, make sure that the person is affiliated with the agency. It was mentioned earlier that to check that, you would have to log into MITS using the agency agency information to log in, and then there's a way to look at all the individuals that are affiliated. I don't believe the individual can do that for everybody, can they, Mary?
Sorry, I was reading questions.
I was just letting them know that to look at the affiliations, they actually have to come in as the agency to be able to see the affiliations, correct, not the individual.
Correct.
they can only see their affiliation, I think.
Correct. Whoever has access to your MITS portal, to that function, it would be your MITS administrator or anyone to whom they have delegated that responsibility, can go in and just look under the group member panel, and that way you can see which practitioners are affiliated with your agency.
Okay. Again, for those individuals who can be Medicare, you need to get them enrolled with Medicare. If you're seeing a Medicare population, caveat there is there have been a number of children's agencies that said we employ those practitioners, but because they're kids, we don't generally see Medicare patients. That's fine. They don't have to enroll if the population they're treating isn't Medicare. So IT, we just covered. Make sure that you're testing either directly if you're your own trading partner, or keep tabs on your vendor who is doing the testing to make sure that they're accomplishing that. We don't actually determine from the state side when a vendor has completed testing. That is a lot up to them to make sure that they're comfortable with the results they're receiving. So I would encourage you to really make sure that you're in touch with your vendor on that to understand what they are testing, and when they say that they're ready, what they actually mean when they're saying that to you. So then work with all your staff too. We appreciate everybody attending the webinar today and hope it has been informative. We do plan to post the recording. We did record it, so then I will have the challenge of making sure it's converted and we can get it out there. We are going to keep the log of questions. I'm not sure we have decided 100% that we'll answer them and post them up there, but we hope that we have been responding to them as we've been going. Okay, this is a lot of change. You know, we've been out working with you all in the field with the work groups. In fact, we've got extensive lists of agencies, individuals, the work groups that we've been holding for the past 2.5 years. When you do something of this magnitude, we will be monitoring the outcome. So there are short-term and long-term objectives. We want to make sure that there is an adequate provider network in the short term. We want to make sure that people are able to access and receive services. We will be watching the claims payment and denied kind of ratio. You can't think of it as, well, if all these denials come through, it's not working correct. There's a lot of times where denial is the right thing. Like we mentioned, if there's misuses of modifiers or coding with practitioners that can't use certain codes. But we will be looking at it as in terms of paid and, denied claims, and just making sure that there hasn't been anything going amiss. So far, the testing hasn't demonstrated any of that.
Testing's going well.
In fact, it has demonstrated that, we've provided some assistance so that some of the vendors would understand some of the changes and things that they needed to realign in their systems. So longer term, you would look at things like people served. We want to make sure that folks are still able to access and receive needed behavioral health services, including the new services, like we mentioned, ACT, IHBT, peer recovery support, SUD residential as per diems. So just monitoring that over time, the premise being we brought the new high need services online for the folks that need them. So we want to make sure that they are receiving them. I think, Mary, you mentioned, around 20 agencies in the ACT world right now. IHBT, I'm not quite sure of, maybe a few less.
It's a few less. It's more like 10 so far for IHBT.
And SUD residential will begin getting loaded up here shortly there. It's not the same because you don't have to go through a fidelity, but we do have to make sure that you have the right provider type connected. And then obviously overall looking at system and service line spending. Just something you do. You monitor the finances to keep your finger on the pulse of the system, if you will. Not that we haven't mentioned it a few times, but bh.medicaid.ohio.gov is out there. I don't even remember when we actually brought this up, but I'm going to say it's been probably 18 to 24 months at this point. We've had it out there. We will caution folks, I caution folks that you can find some of our older information still on the website, but the further back you go, the less accurate it is. So that's...
Always look at the most current version of the manual, the workbook, etc.
Yeah, so you can go there. We encourage folks to sign up for the BH Redesign newsletter if you haven't. And at the bottom left of this slide, there's actually a spot on the MHAS website where you can sign up for our BH Providers listserv. And we do tend to send things a lot of different routes just to get information out and in the system. So you may receive things multiple times, but that's better than not receiving anything at all. So we do try to communicate a lot of information targeted. I think our MITSBITs today, we are like 40 days from go live. So, all right, we will go back to questions. All right.
This is
ODATA supplied a form that categorized patients by levels. Having the history on the ODATA side, we did have the ODATA's level of care protocols. Those have not been used for about a year, part of the combining of ODATAS and ODMH. From our certification side, we dropped the proprietary system, albeit very similar to ASAM, but have moved over to the ASAM criteria. We don't require forms ourselves. We don't require providers to use the American Society of Addiction Medicine Continuum product, but you are responsible for utilizing and applying the ASAM criteria. The rules filed with JCAR do not include the 100% reimbursement rate for TBS PSR over 90 minutes. That's when it's not provided in the office or the CMHC. The slide shared this morning is correct. When will the workbook be final? You know, it's pretty much, you need to consider it final when we issue it. I don't believe we are apt to make any more, pardon the finger quotes, high-level policy changes at this point. So we would expect that you would begin using any and all version that you had. Recommendation, make sure you get the most recent one because that has some of the clarifications. Sometimes it's a simple, we missed putting something in because there's a lot of materials that we're handling. When will the 837 companion guide be available?
the IT resources. Yep. There is a requirement that the 837 guide not be formally issued and final in its final form until after go live. So don't wait for that. Look instead at the IT resources page on our bh.medicaid.ohio.gov website, and you can get all of the information that you need there regarding EDI file loops, segments, and coding and composition. Rules, understanding there isn't a per diem reimbursement that would support crisis stabilization units in the community. Is it ODM and Ohio MHAS's opinion that individuals should be stabilized in their own residence until they decompensate to the point where hospitalization is required? No, that is not our perspective. I think we are giving you clinicians with a clinical scope of practice a series of tools and rates to perform crisis stabilization and crisis intervention services. Please take a look at the coding chart and at the manual for all of the services that can be provided for crisis services. And then when the crisis has been resolved to the point that the person is not in danger anymore, then there are other services that can be provided. We have never provided a per diem reimbursement for crisis stabilization units from Medicaid. So just please familiarize yourselves with the services that can be performed and billed for crisis type intervention. I'm trying to find the most recent version of the rules. Go to the Register of Ohio is the best place to find the most recent version of the rules. And OAC Chapter 3793, I don't think we have anything left in 3793. That is the chapter that formerly held the rules for the Ohio Department of Alcohol and Drug Addiction Services, which hasn't existed for 2 years now. So don't go looking there. Look at the Register of Ohio. You're going to want to look at 5160-27 and 1 through, I believe it's 12 or 13 for the Medicaid rules, and 5122-29 are the chapters where mental health and addiction services rules are posted. You can search by rule number, you can search by agency. Go to the Register of Ohio and you can find the rules. Does a CDCA or above need to monitor the drug screen as the client provides the sample in order to bill the service? Doug?
When obtaining a urine sample, yes, you still have to do a chain of custody to assure that it doesn't get adulterated during the collection. And yes, generally one of our practitioners, you can't have a peer or a trained other, so yes, you do need to have an actual SUD professional with that in order to bill the collection code, which is what that really is in the future, since we pulled the whole lab part out and now the labs will be billing directly. So yes, you still have to assure a chain of custody to assure that the specimen is not tainted in any way, shape, or form. Place of service 23, hospital, emergency room. The slide said it will be allowed for crisis, but CPST allows for billing to help coordinate admissions and discharge. We'll be able to bill CPST if the CPST staff is at the hospital.
Well, we've changed our policy, and that was in the slide deck, on allowing services to be provided in the emergency room. So go back and take a look at the slides in this deck that we just covered earlier on that policy change. When will the final version of the provider manual be released? It's up there. As we said earlier, just check and make sure you're looking at the most current version of any of the resources at the bh.medicaid.ohio.gov website. We currently use location 56, Psych Residential Treatment Center, and Public Health Clinic 71, which aren't on the list of locations. Would 99 be a reasonable substitute? No. There are many other choices. I don't believe that either of these are acceptable places of service for the benefit package that's going in place July 1. So do take a look at the places of service. I would think that if you're performing service in an office, you might choose the Community Mental Health Center. You might choose 11 office. Take a look at them. 99 is reserved for a place of service that isn't covered by one of the other places of service. If a service is allowed by point of service codes, I think you mean place of service codes, provided by an allowed clinician to authorized client, can it be provided out of state? For example, providing linkage to a social service agency that is just across the state line for specialty services. So I guess I would point you to the manual in terms of looking at the allowed places of service. You would not want to choose an out-of-state place of service because it seems to me the service is occurring in-state. You're arranging service for someone else, and you would need to take a look at the requirements for services like case management that allow for those kinds of arrangements of service. Is Medicare billing a different site? We never billed Medicare before. If you are serving Medicare clients, you should be billing Medicare. If you're not serving Medicare clients, you don't need to be worrying about billing Medicare. If you are serving Medicare clients, you would need to contact Medicare and become familiar with their billing process. If we bill Medicaid through the MITS portal, do we need to do testing? No, you don't. And testing isn't open for the MITS portal. We're testing for EDI files right now. How can you validate that your trading partner has tested and been approved? Is there a list? You might want to call your trading partner and ask them about that. That's a service that you're buying from them, so give them a call. We have 2 providers who have not yet received their letters but are showing as affiliated to our agency. They were asked to resubmit their W-9 and did so in March and still have not received the letter. How's the best way to check on this? Why don't you send us an email at bh-enroll.medicaid or at medicaid.ohio.gov, bh-enroll@medicaid.ohio.gov, or you can also comment on the bh.medicaid website. There's a contact us link on that website, and we'll get with you separately. Do agencies need to be certified through Ohio Mental Health and Addiction Services to provide peer support services? Yes, they do. And the peer support specialists also need to be certified. Does the website indicate this is final, or is it still in draft? I would consider the documents that are on our website final. They're all going to say draft because we are tracking the changes as we move along and make policy changes. But as Doug said earlier, I think we're in the final stretch here, and we don't intend to make any other major policy changes between now and July 1. Did I miss clarification of 99211 should not be billed on the same day as 99213? If a nurse sees a patient, H2019 is to be used when appropriate. Is that correct on the crosswalk? So we do have a policy change that you would not bill 99211 and 99213. 99211 is the only CPT code that can be billed by an RN or an LPN. That's the lowest level existing patient office visit. You would only bill the 99213. However, if there is a nurse intervention that occurs during that visit, you can bill the nurse activity in addition to the evaluation and management code. So we provide psychotherapy in places in the community that don't seem to be covered by any of the POS, in the park, a court, or public setting. Is psychotherapy in these locations no longer covered? Look at the manual on the places of service that are allowed for the psychotherapy codes. I would just direct you to the manual for psychotherapy codes. We do have allowances for place of service 99, which is community, for certain of those codes. I'm not going to try and remember right now what's allowed for which codes, but please look at the manual on that. Can an LISW or an or LICDC NPI be the supervisor over CDCAs doing IOP groups, or no, not at all? Do you understand this question?
I think so, and I believe the answer is that if you have a CDCA who's facilitating an IOP group, and in this person's example, that would be, I'm assuming, direct supervision, because they would be there on site. I believe that, yes, an LICDC or an LISW could be the direct supervisor or general supervisor, not to be confused with the credentialing board's clinical supervisor. So where's the information on the companion guide for the 837? I don't see anything under IT resources. You need to, I know some of it is in the slide decks, so it's not an actual companion guide by itself. That's, I believe, what Mary indicated. We won't actually be able to post that until July 1st. If a patient sees a psychiatrist for med management and a counselor for therapy on the same day, can both those services be billed on that day separately? They actually would be, because you have different practitioners and different services. In the presentation, it states that there is no benefit limit for crisis services, but there are NCCI MUE edits. That's correct. We state that there is no state-defined benefit limit, but that all NCCI edits do still apply. On the urine collection, is this for collection for an on-site lab? We use a cup that tests for 11 drugs. Is this billable? Yes, that would be the collection, and you're using the iCup for a point of service result. Slide 57 was the H0005 code without modifier omitted by mistake. No, because that slide is specifically about licensed practitioners. The physician, which is the AF modifier, the H0005 code has always been there for the unlicensed practitioners. So it was not omitted by mistake, but that slide is specific to licensed practitioners and the physician. When will testing for the MITS portal open for everyone? Again, manual claims entry is not subject to testing. EDI transactions are, and that is open to everyone right now. Do agencies need to be certified in crisis service in order to provide psychotherapy for crisis? Yes, Ohio MHAS still has a crisis services regulation. It's out there in the new grouping of certification rules, so please go take a look at them. Very specific health home question. It's been extended for 6 months. Is the same billing code used and the reimbursement the same? Yes and yes. I believe, can IHBT service be billed with a collateral when the client is not present? We'll have to come back to that one. If there's no companion guide prior to testing, what's the back date you'll allow for claims? Well, this will be subject to all claims July 1st, and the companion guide will be available July 1st also. Please keep in mind that it's interesting, the questions about the companion guide, because we are not changing any of the structure to the 837P file. In fact, we cannot do that. It's really data content, policies, and that's why we've published the myriad of other information, the IT resources that are out there, the provider manual. I did mention earlier that in a number of those EDI IT slide decks, you will see language in there that talks a little more specifically about what goes in certain fields. So you can do an IOP group without a licensed person in the group. Can you clarify? Well, CDCAs are qualified to provide group counseling under their credential. So the earlier question about it seemed to lead us to believe that they were asking about a CDCA who's leading a group by themselves under direct supervision, immediately available and interruptible. If you have other additional questions about that, would direct you to the Chemical Dependency Board themselves, but it's our understanding that group counseling is within the purview of a CDCA and always has been. Does the client have to be present for psychiatric assessment? It is often beneficial with children to first meet alone with the parent. I apologize, but you're walking into a number of different things. If the client has not been some level of assessed, you don't have a patient. So anything you're doing with anybody prior to that is not going to be covered because you have not established a patient relationship. So in some ways, the answer is you need to be sure that you have assessed and engaged in the patient relationship first, because that's how you get the diagnosis, that's how you develop a treatment plan, and that's how you can begin providing services. And then subsequent to that, there are services that can be provided on behalf or through collateral contacts. Prolonged psychotherapy services. I see the prolonged code for psychotherapy for crisis. What about 90837 that goes 90 or 120 minutes? I believe that, please check your CPT book, but I do believe you can add the prolonged to the 90837. Yeah. We defer to CPT coding. So if it's allowable there, you can certainly use that. I believe Cicely mentioned earlier there may be times where you might want to consider some variation of the mental health day treatment, but when it comes to CPT codes, we follow what's in the CPT coding.
To follow up on the psychotherapy allowable place of service, per the provider manual, 99 is only allowable with the UT modifier in crisis. That's correct. We do provide counseling in a park, community center, or library. It's often in lieu of the client's home for a variety of reasons. Will this no longer be allowed after July 1? There is a combination of codes that are available in the benefit package. Some of them are called psychotherapy, and those must be provided by licensed clinicians. Some of them are called counseling. Some of them are TBS and PSR and CPST. So if you look at the code and match it to the activity that is occurring, that's what you would bill. Some of them are available in place of service 99 and some of them are not. So keep looking at that manual. Is place of service 57 intentionally left off H0001 in the manual? I don't know what place of service 57 is. Do you, Doug?
Non-residential SUD treatment program.
Is it intentionally left out of the manual?
You can use place of service 11 in lieu of 57 for that.
It was mentioned in previous trainings that a prolonged procedure to individual psychotherapy may need prior authorization. Is this not true? It is not true. There's no prior authorization required for a prolonged procedure code. That's an add-on to a variety of the CPT codes, and it does not require prior authorization. What it will require is that you meet the criterion for prolonged service, and that's documented in your medical record. Are claims prior to July 1, 2017 to be billed as the current billing process? That is correct. July 1 of 2017, that date of service is when we will change from the current billing construct and benefit package and rates to the new construct and benefit package and rates. So at 12 o'clock midnight on July 1, 2017, any service that occurs at that moment or after, you will use the new billing code, the new billing mechanism and rates and benefit package. Any services that occur between or before then, you will use the current billing package. For location codes for youth on probation, is it appropriate to bill, say, a 90791 and would location code be 11 or 99? I'm not going to get into giving you advice about what code you should be billing for what activity with the youth. I will make a comment, however, with regard to the federal law with regard to inmates of a public institution. Just make sure that the youth that you're treating does have freedom of movement wherever you are treating them. If they do not have freedom of movement, if they're in a detention center, if they are in court, Medicaid cannot pay for their services, and that's according to the federal law. Expand upon the rules regarding supervisors regarding direct supervision of a trainee. Does it have to be the supervisor on record? Could it be any supervisor? Yes, it could be any supervisor who has the scope of practice to supervise the trainee and who is supervising the trainee on the day that the service is rendered. Is there a definition of resource that we can access to assist with defining appropriateness of prolonged service. I would refer you to your CPT book. If your agency doesn't have one, you should get one. Are there any issues with loading billables with UCC rates that are comparable to agency billing rates? I'm not sure I even understand this question. Do you understand it, Doug?
Yes. So I'll interpret it a little bit. An agency generally establishes their usual and customary charges. I believe that's the UCC rates. So yes, you should still do that, and that's what you charge. And in the case of a Medicaid claim, that's how you calculate the billed amount. And then MITS itself does the mathematics when the claim comes in, and it will pay the lesser of the charged amount or the Medicaid rate. So it's the lesser of. So yes, your current practice, you just need to continue it, and you may need to establish UCCs by practitioner level too. Last question again here. Just looked in the manual and don't see the criteria for prolonged service. Where would you find this? We have mentioned you need to look in the CPT book, the current procedural terminology book that you get from the American Medical Association. It's what your physician office uses to bill medical claims. And within that is where the AMA documents the criteria by service, which includes the prolonged service codes here. And with that, we actually have cleared all the questions that have been submitted.
So I did find an answer. We had a couple of questions about the EDI billing guide. And I checked with my colleague, Nicole Small, and she says that the information that you would use in place of the final EDI billing guide is in the most recent PowerPoint slides from the EDI work group. So if you go to the bh.medicaid.ohio.gov website and look for the slide deck from the April 26th meeting of the EDI work group, you will find that information in that PowerPoint slide deck.
So with that, thank you for attending today. We did record it, so hopefully we'll be able to put this out on the website for others to view. Hopefully it was informative, and thank you again for attending. Have a good afternoon.